Good afternoon, distinguished guests. The meeting will start in 3 minutes later. Please take your seat first. Everyone, please take your seat. Everyone.
Good afternoon, every distinguished guest. Let's welcome the Vice CEO of Coleman, President of International Marketing Department, Mr. Gary Choi, to the stage for the opening speech. Please give us a big applause.
Distinguished experts, colleagues, and friends. Good afternoon, everyone. I'm Gary from Coleman Medical. As the Chinese New Year is approaching, I would like to extend my warmest welcome to all of you, as well as the experts, colleagues, and friends which are participating online. Thank you for participating and wish everyone an early happy Chinese New Year and good health. Wish you 马到成功. Today, we are honored to have Professor Daniel La, President of the World Federation of Society of Anesthesiologists, Professor Vavini, President of the Asian Australasian Congress of Anesthesiologists, and experts in the field from different countries today here. We also extend our heartfelt warm welcome to all our peers and friends participating online. Anesthesiologists are indispensable guardians behind every surgery, playing a crucial role in every surgery, safety management, and the patient health care, yet often working behind the scenes. That is one of the reasons that we host the competition today, called Anesthesia Share with the World. Through the highly simulated real-life cases competition, participants must make swift decisions, collaborate with the team, and based on their judgments and the solid clinical knowledge and experience. This is not only a challenge in the competition, but also a true representation of the daily work of every anesthesiologist. As one of the leading global manufacturers, Coleman Medical always insists to the principle of all for the end users. We firmly believe that only by immersing ourselves in clinical practice and listening to the voice of the end users, we can translate feedback into continuous improvement in our product and the solution, contribute to human health care. Nowadays, Coleman offers integrated solutions, ICU, OR, NICU, ER, ultrasound, and the endoscopy system. As the showcase here today, we provide integrated operation room equipment and for the end users, encompassing not only a full range of the equipment, but also integrating anesthesia management system and the digital OR system. Through such critical academic exchange activity with the top global platform, Coleman continue to deepen our clinical center's value, actively engage in real medical scenarios, and contribute our professional appetite to enhance anesthesia safety, improving healthcare quality and addressing clinical challenge. Next, it's my great honor to invite Asian representative of the World Federation of Society of Anesthesiologists, Professor Sulavong Losombredi, to serve as the moderator of today's competition. Let's give a warm round of applause to welcome Professor Sulavong. Thank you.
I have to run up on the stage. Thank you, Coleman, for organizing such a wonderful event to increase the abilities of the whole Asia in Australia for the patient safety and to connect each other together for the crisis competitions. I cannot be only one moderator. May I invite my co-moderator as well, Professor Maliwan from Prince Songkhla Nakarin University, Thailand. Before we start this competition, because this is part of the World Federation Society and Anesthesia to increase the ability of our country, even though we are different country, but we can go to the same directions of the guidelines, same direction of the patient safety, and how about the encourage the people to work together very well. I would like to invite the president of the World Federation Society and Anesthesia for giving the opening speech. May I invite Dr. Nadella Filippisco, please.
Okay. Good afternoon, dear colleagues, judges, participants, and friends. It is such a pleasure to be here today with you. As president of the World Federation of Societies of Anesthesiologists, I am honored to open this flagship event of the Asian Australian Congress of Anesthesiologists 2026, the Live Anesthesia Crisis Challenge. On behalf of the WFSA, I congratulate the organizer, the AACA Organizing Committee, the Asian Australasian Regional Section, and commend Medical for addressing the cutting-edge challenges in the field of anesthesia today. We come together with a shared purpose to improve patient safety and advance anesthesia care worldwide. This event is not just a competition. It is a learning platform that brings us together across borders to share experience, build skills, and strengthen our global community. You might know that the WHO Global Patient Safety Action Plan 2021-2030 aims to foster policies, strategies, and actions based on science, patient experience, system design, and partnership to eliminate all sources of avoidable risk and harm to patients and health workers. Simulation is mentioned many times in the WHO working plan. Simulation, why? Because simulation enhances safety culture and team performance, enabling clinicians to adapt to the changing demands of healthcare systems. It supports the development of skills and prepares health professionals to manage complexity. It improves team performance in managing a variety of cases, as well as foster workforce well-being and resilience. Simulation also has a crucial role in the analysis and optimizing of work system. Furthermore, simulation practice positively impacts patient outcome, reducing mortality and morbidity and helping improve patient experiences. The recent global consensus statement on simulation best practice in healthcare developed through a collaboration between 50 national and international simulation societies and networks has highlighted the worldwide impact of simulation, and it emphasizes the importance of integrating it into daily learning and practice in healthcare environments, but it should be cohesively supported by institutions and governments in terms of political, strategic, and financial commitments. It would be wise to consider that the best way to predict time is staying ahead of times. Education-wise, how we train will continue to evolve and revolve around simulation. Therefore, we should use simulation early and extensively in our educational programs. We at WFSA believe that through education, collaboration, and shared experience can improve anesthesia care for every patient, everywhere. Therefore, the significance of today's simulation contest cannot be understated. With the rising complexity of clinical cases in the ever-evolving technologies, hands-on training in a controlled and risk-free environment is instrumental in building competency, enhancing confidence, and promoting patient safety. Today, we welcome teams from 8 countries. Each of them represents excellence, teamwork, and dedication to their patients. And through simulation, they will demonstrate not only clinical knowledge, but also communication, leadership, and resilience, skills that are essential in every operating room worldwide. Thank you, judges, for your expertise, for creating this meaningful educational opportunity. And for participants, I hope you will give your best, learn from each other, and build connections that will last beyond today. And I noticed that we are also online, so everyone will be joining us and be part of the journey. And we continue to learn together today, support one another, and strive for the highest standards of care for every patient we serve. Thank you for your attention, and now let the live anesthesia crisis challenge begin.
Thank you very much.
Thank you so much, Dr. Daniela. Now, may I invite Associate Professor Dr. Warini Rekpasert, Conference Chair of the 17th AACA 2026 Asian Australasian Regional Section Board member, to give welcome speech.
Good afternoon, dear colleagues, distinguished experts, and dear participants. It is my great pleasure to welcome you to the Co-Anesthesia Share with the World Live Anesthesia Crisis Competition Case Demonstration Challenge. This competition was established with a clear purpose: to create a platform where anesthesiologists from the Asia and Australasia region can share experience, demonstrate clinical excellence, and learn from one another through real-world case discussion and professional exchange. I am delighted to see 10 teams from different countries and institutions coming together today, reflecting not only the diversity of our region, but also shared commitment to advancing the quality and safety of anesthesia care. I want to express my sincere appreciation to all participants, judges, organizing members, especially Coleman, Edwards, and Torrent, for your dedication and enthusiasm. Your involvement is what makes the competition meaningful and impactful. Although I am unable to be with you in person, this event will be inspiring, educational, and rewarding for everyone involved. I wish all teams great success and an enjoyable competition. Thank you.
Thank you very much. Before we join to the next top 10 team of the whole Asia, may I introduce the judge? The judge is the top judge from the whole Asia. The first, may I introduce Dr. Wei Morris from New Zealand for the judge, please. And the next is Dr. Lawrence Weiberg from Australia. Lawrence, please stand up, please. And the next judge is from Korea, Jack Kwang Shim. He's the president of Korean Society of Cardiovascular Anesthesia. Hasmi Si from Malaysia. He's the president of Malaysian Society of Anesthesia.
Yes. The next from China, he's Dr. Chang Long Yao from China, the third president of the Anesthesiologists branch of Chinese Medical Doctor Association.
And next is Suhaini Kadiman from Malaysia. IJN, the very big cardiovascular surgery in Malaysia. And next is Dr. Biswas from Nepal. Very good cardiac surgery in Nepal as well. And the president of Hong Kong Society of Anesthesia, Dr. Yao Chi, please.
Yes. Next, Dr. Ting Ting Wang from China. She's Deputy Director, Department of Anesthesiologists, Union Hospital, Tongchi Medical College, Huang Song University of Science and Technology.
And the well-known anesthetist in India as well, Dr. Niran Baswa. And also famous anesthetist from Nepal, Dr. Ashi Amatya.
And we also have special guests from different countries that can give us the comment of the competition.
So how many VIP guests? Because we have a lot of VIP from Romania, Philippines. Where's Philippines, please? China, Indonesia. Where are you? Korea. Thank you very much.
Also from Russia as well.
Russia.
Yes, Russia.
Brazil as well. Saudi Arabia as well, right?
Yes, Saudi Arabia.
And a lot from Malaysia and also from live, right?
Yes.
Live broadcast as well.
Right.
Before we go into the competition, let's clarify about the scoring system. You can see that the scoring system is for the case design and clinical management guideline, technical performance, and anesthesia non-technical skill, how you communicate each other with the team and the debriefing impact. And the case should be, at least the case should be, show that this scenario can happen anywhere around the world. And how can you solve this problem without the equipment or with the equipment, even though the guideline is this way, but you don't have the equipment, but you have to go to this guideline in your scenario properly, is correctly or not.
Right, so the total score is 100%. So we would like to have a transparency and very clear criteria for the judge to make a winner today, and also champion, and also first rounding up.
Yeah, and it should be belong to the guideline of the BVSSA, guideline of the famous journal, and it should be correct. And next is, it should be very good project skill and monitor the reassessment, how about the communication, is it available or not. And the last but not least is situation awareness. The sharing situations, closed loop communication or not, teamwork and leadership, is it available or not, and about the assessment of performance, is available or not. And the champion, we will have the first runner-up, second runner-up, outstanding performance, and most popular award. Let's start with the first team. First team, please. We will start with China.
Hello, everyone.
China, please ready on the stage, please.
I'm prudent and considerate. I'm from Zhongshan Hospital.
Hey everyone, I'm Gu Jiahui. I'm outgoing and optimistic. I'm from Zhongshan Hospital, Fudan University.
Hi, I'm Iris Chen. I act as a nurse this time. I'm from Zhongshan Hospital, Fudan University. Wish all you enjoy the simulation competition this time and enjoy the congress. Thank you.
Hello everyone, I'm Wei Yazhong. I am a junior anesthesiologist from Zhongshan Hospital. Connect care.
Ensure safety.
Future.
We step forward.
Prepare, lead,
and inspire. We are the forever.
You have 15 minutes for showing the scenario. Let's start.
Good afternoon, distinguished guests, honorable judges, and dear friends on internet. We are
Forever!
Sawadee-ka! I'm Iris, Dr. Chen, and this is Dr. Lee. Both of us are senior anesthesiologists. In this simulation, my role is a nurse. This is Chris, Dr. Gu, and Dr. Wei. Dr. Wei plays a role as a surgeon. They are our junior anesthesiologists. Now let us welcome Chris, Dr. Gu, to give us the case background briefing.
Thanks for Iris' introduction. And now let me briefly introduce this case. Today, we want to present a high-stake case in the operation room. Intraoperative hypertension and hypoxia in an elderly patient. Our patient is an 83-year-old gentleman with hypertension for 10 years and no other special comorbidities. Undergoing TURP, transsexual resection prostate. And today, our anesthesia plan is spinal block. Now let's just come to the stage to see what is happening.
How's it going, Chris? Is the spinal anesthesia down?
Yeah, Dr. Lee, very smoothly. 10 minutes ago, 10.5 milligram bupivacaine was administered between the lumbar 3 and 4 interspace with a dilution of CSF, and the sensory block level was assessed at T6 now.
Perfect. Iris, remember to keep the patient warm. And Chris,
Yes.
keep an eye on the fluid load.
Okay, of course.
Iris, the irrigation fluid is almost empty. Don't forget to replace in time.
The surgery has been lasted for 1 hour. 10 bags have been used so far. Should I prepare another 10?
Yes, perhaps 10 more bags. This patient's prostate is really large, and the procedure is way harder than I thought. So it might take another hour.
Oh, wait. Hold on a second. The patient EKG is changing. Surgeon, what are you doing right now?
Nothing unusual, just following the standard surgical procedure, and almost done. What's wrong?
Sir, are you uncomfortable?
Sir, don't move. Try to stay still.
I need to circulate the lungs. The vital signs seems unstable. Iris, please measure the blood pressure again.
Okay.
Any problems?
Oh, no, Mama. The heartbeat pace seems acceptable, and the lungs sound clear at the moment.
You need to do something. He's moving. I can't go on like this.
Okay, I'll give some medicine. Iris, please. I'll give 2 milligram midazolam and 10 milligram furosemide. Oh, wait. The patient's condition is getting worse. Surgeon, are you sure not any special maneuver has been performed?
Nothing special.
Oh, I will first increase the oxygen flow. Iris, how many bags of irrigation fluid have been used?
1, 2, 3, 15 irrigation bags so far.
15? Oh no. Not much bleeding, right?
Bleeding is minimal and totally under control.
Bilateral moisture, and the saturation is only 19. And 15 bags. I'm afraid he's developing TURP syndrome. Iris, stop the irrigation fluid immediately.
Stop the irrigation bag.
And I will reduce the maintenance of IV fluid. There are more and more secretion from his mouth. Iris, suction right now.
Chris, the secretions look a little bit pink.
Yeah, you're right, pink. Oh no, the patient is developing acute heart failure. Please call my attending at once. I need help.
Blue coat, Dr. Lee, room 401 need your help. Dr. Lee!
On my way. What's up, Chris?
Yeah, Dr. Lee. This is a patient schedule for TURP. We performed spinal anesthesia as usual. He was very stable for the first hour, but suddenly he developed a rapid atrial fibrillation and hypoxemia, and the bilateral lungs revealed moist areas. I'm afraid he's developing TURP syndrome. So I gave 2 mg midazolam to sedate him and 10 mg furosemide to reduce the fluid load. And now I'm considering initiating the nitroglycerin infusion. Do you agree?
That makes sense. Start nitroglycerin infusion at a speed of 0.5 microgram per kilo per minute.
Okay, microgram.
And place an arterial line.
Arterial line, got it.
Iris, prepare the induction mats for general anesthesia. And can you draw an ABG for us?
Dr. Lee, here is the result of the arterial blood gas.
The ABG indicates hypoxemia and acidosis.
Yeah.
But electrocytes are within normal range.
Yeah, normal.
Chris, we need to intubate this patient now.
Okay.
Let's start injection. Put on the face mask properly.
Yeah.
Sequentially inject 15 mg etomidate, 60 mg rocuronium, and 150 microgram fentanyl. The vocal cords clear?
Yeah, very clear.
This patient had no major systematic comorbidities or heart diseases. Why this is happening?
Surgeon, stop blaming. Calm down, please.
Okay.
The blood pressure is dropping. Administer bolus of 100 microgram phenylephrine. And start norepinephrine infusion at a speed of 0.03 microgram per kilo per minute.
0.03, got it.
The hemodynamics is still unstable. Another bolus of 100 microgram phenylephrine and raise the speed of norepinephrine to 0.06 microgram per kilo per minute.
0.06, done.
After intubation, the oxygenation has improved, but the hemodynamics is unsatisfied. Let's do a TEE to find the cause. Iris, can you bring us the machine here?
Of course. Dr. Lee, here is the ultrasound and TEE probe.
Thank you. The myocardial contractility seems normal.
Yeah, normal.
Let's take a look at the middle esophageal lung axis with Doppler. You can see mosaic pattern in the LVOT. It might be SAM.
SAM? What is SAM, Dr. Lee?
SAM, systolic anterior motion of the mitral valve.
I only read it in the book. Can you show me again?
Of course. Let's check it over.
Yeah.
Confirm, it is SAM. We need to change our strategy.
What should we do?
Increase the IV fluid now.
Okay.
And Chris, stop the nitroglycerin infusion.
Stop it.
And up-titrate norepinephrine to 0.1 microgram per kilo per minute.
0.1, done.
And prepare Landilor with a loading dose of 4 milligram,
Landilor, 4 milligram.
followed by continuous infusion at 5 microgram per kilo per minute.
5 microgram per kilo per minute. Got it.
The hemodynamics stabilized gradually, and the EKG has converted to sinus rhythm again.
Marvelous job! You guys are such a great team. Figure out the hypoxia and hypotension so fast. I will complete the surgery as soon as possible.
Surgeon, I recommend this patient to be transferred to the intensive care unit for post-operative monitoring.
Agreed, I will contact with the ICU team.
And request an overall cardiac consult from the cardiologist, please.
Good call, I will do it. Thank you again.
Okay, the crisis case is over. Now let's just come back to the stage to conclude it. Today, we managed an 83-year-old hypertensive gentleman who happened sudden hypoxia and hypertension approximately 1 hour after spinal anesthesia for TURP. His initial presentations, including the pink fuzzy sputum, desaturation, and the bilateral crackles, strongly mimic the pulmonary edema caused by the overload of fluid, or the TURP syndrome. Based on this assumption, and we did the medications, including the furosemide, nitroglycerin, and reduced maintenance IV fluid. However, these medications just wasn't the condition, and finally developing into the rapid heart failure and cardiovascular collapse.
The critical turning point was the prompt use of TEE. The initial TEE reveals mosaic pattern in the LVOT with regurgitation jet. Because of the atrial fibrillation, it is difficult to measure the movement of the mitral valve, but all these signs are suggestive of SAM.
So, we immediately shift our management. First, stop the vasodilators and initiated aggressive liquid resuscitation. Increase the vessel pressure support with norepinephrine to maintain the afterload. And then, administered the ultra-short-acting beta blocker, Landilor, to control the heart rate and contractility. This patient's hemodynamic and oxygenation stabilized rapidly. Yeah.
So the key lessons from this case are threefold. First, SAM can be a great masquerader, presenting identically to volume overload, especially in a setting like TURP, where the fluid absorption is expected. Second, echocardiography can be not only a diagnostic tool, but also a crisis management essentials in the OR. Finally, this case underscores the importance of considering the dynamic obstructive in the LVOT, especially in the patient with unexplained hypotension and hypoxia. Our initial treatment from the wrong diagnosis actually inadvertently exacerbated the true problem. Thank you very much.
ขอบคุณค่ะสวัสดีปีใหม่
Thank you very much, Zhongshan University, Fudan University. Congratulations. We will have 5-minute discussion from the judge, and in the same time, we invite the second teams on board, ready for the next team. We will have 5-minute discussion for the judge. How about these scenes, please? We're starting with the TURP, right? We thought that it will be like you have TURP syndrome, fluid overload, like something like that. The microphone is ready for the judge to comment, please. Hasmizi, please. The microphone, please.
My name is Hasmizi. I have 2 questions. One is, you know that it's, of course, in conventional study now, if a regional and TURP syndrome, basically is a patient you think is pulmonary edema, then you hemorrhage unstable, you intubate, you know, and then, but again, if you give a general anesthesia like this case, you have a difficulty in maintaining the blood pressure. You need to start with inotrope. Have you thinking of start using CPAP or hyperintensive cannula? Because first initiation is your aim is to improve oxygenation, and then that's your first question, whether you thinking of giving a CPAP or hyperintensive cannula, because your initial diagnosis is a pulmonary edema. And then the second is why TEE? Why not transthoracic echo, which is commonly available? TEE is a very high, not all hospitals have TEE. Thanks.
Okay, we answer the second question first.
While TTE could be adapted, TEE is superior for several reasons. The patient was in the thoracic position and draped for pelvic surgery, making acquiring TTE windows even more difficult. While TEE could consistently provide high quality, unobstructed view of the mitral valve apparatus and OVT directly behind the heart. In the incubated patient, TEE could be easily inserted and does not interfere with surgery or resuscitation efforts, providing a stable diagnosis image during the ongoing CPR or hemodynamic instability.
The first question, Dr. Lee.
Thank you very much. Please put 5 microphones on in the front for the judge to comment, please. 5 microphones. Thank you very much.
Love the scenario. Great teamwork. A very common situation. Well done and huge congratulations.
Thank you.
So we can all learn, and this is very generalizable to many countries all over the world. Well done on running your norepinephrine. What concentration did you draw your norepinephrine up when you were running it peripherally, and why?
You mean norepinephrine?
Yes.
Titrate the norepinephrine?
Yes, my question is, well done, good choice of drug. You ran
why we use norepinephrine?
No, what concentration did you mix the norepinephrine up to run it peripherally? It's a very good educational message for those that may need to use the drug peripherally.
The concentration, our concentration is how can we titrate?
Because we use a peripheral norepinephrine instead of central.
Our concentration is 0.03.
And then up titrate to 0.06, and then 0.1
microgram per
kilo per minute.
And what strength did you make your noradrenaline in? What dilution was your noradrenaline per mil? Because it could be dangerous to run norepinephrine at a high concentration peripherally in case of tissue extravasation. So just as a learning exercise, it's a very important management skill that you did, and we congratulate you. I'm just interested in what your concentration was of your norepinephrine.
If the patient's body weight is 70 kilograms, so 0.03 will be...
I see. 20.
Don't worry.
Wait.
Thank you very much, Fudan University. Big applause for Fudan University. We will move to the next team. Okay, thank you very much.
Thank you.
Thank you.
Invite the team from India.
Hi, I'm Dr. Shreya Modi, cardiac anesthesia resident at Marengo Sims Hospital, Ahmedabad.
Hi, I'm Dr. Meet Kanasagra, third year cardiac anesthesia resident at Marengo Sims Hospital, Ahmedabad.
Hi, I am Dr. Chintan Sheth, consultant cardiac anesthesiologist and co-director heart transplant program at Marengo Sims Hospital, Ahmedabad.
Hi, I am Diksha Patel. I am a cardiac nurse anesthetist at Marengo Sims Hospital, Ahmedabad, India.
Namaste and good afternoon, respected juries and dear friends, colleagues and ladies and gentlemen. We team from India. I am Dr. Chintan Sheth. I am lead cardiac anesthesiologist. He is our second year resident, Dr. Meet. He is going to play cardiac surgeon. She is our resident, Dr. Shreya. She is going to play associate anesthesiologist. And she is our nurse anesthesiologist, Disha Patel. She is going to play assistant surgeon. So we are starting with our case. So we team from India is going to present a case of 77 years old male patient who had history of anterior wall MI 1 month back. He has undergone coronary angiography outside of some other hospital, and he was diagnosed triple vessel coronary artery disease. Patient was advised for the CABG operation, but patient and relatives refused at that time. Now after 1 month, he is presented to us with the acute decompensated heart failure, signs and symptoms comprising he had orthopnea, dry cough, nausea, and pedal edema, gross ascites. We admitted this patient to our surgical ICU, and as we can see on the transthoracic echo, LVF is just 20 to 25%, moderately severe MR, grade 2 TI. From TI jet velocity, PA pressures are 75 mm of Hg, that is very high. IVC is 22 mm and non-collapsible. And lab reports, he has increased serum creatinine, borderline increased liver enzymes. Sodium is 122, that is because of dilutional hyponatremia. Anti-proBNP, which is the marker of heart failure, is very high, 12,250. We inserted Swan-Ganz catheter to optimize this patient, and as we can see, cardiac index is just 1.3. PA pressures are 70 against the systolic BP of 85. So whenever systemic systolic BP is 85 and PA is more than 2/3 of the systemic BP, which suggests severe pulmonary hypertension. So we optimize this patient by starting the injection dobutamine 5 microgram per kg per minute. We wanted to do diuresis because there's an acute congestive state. So we started tosemide, eplerenone, and metalazone as a sequence and nephron blockade. We started injection vasopressin 1 unit per hour to maintain the mean arterial pressure, because if at adequate mean arterial pressure, it can provide adequate coronary perfusion pressure and also the renal perfusion pressure, then we can have better diuresis. We started bisoprolol and ivabradine and magnesium sulfate as a rate control and arrhythmia prevention. We daily checked ABG and maintained serum potassium 4 to 4.5 milligrams per liter. And after 72 hours of dobutamine, as dobutamine developed tachyphylaxis after 72 hours, we switched over to levosimendan 0.1 microgram per kg per minute. And after 24 hours of levosimendan, and total 4 days optimization on echo, EF is 20 to 25%, but MR, which was previously moderately severe, it is now only mild. PA pressures, which were 75, now it is just 42. Cardiac index has been improved, and anti-proBNP, which was 12,000 before, it is now just 854. So we have optimized this patient well, and now we have subjected this patient to cardiac MRI to see for the viability, whether it is possible to undergo CABG operation or not. So on MRI, as we can see, there was only 30% scarring and 70% myocardium was viable. So we posted and accepted this patient for the CABG operation, and we induced this patient with etomidate, fentanyl, and cisatracurium. We have connected all the invasive and non-invasive monitors, and right now we have successfully completed all 3 distal anastomosis with stable hemodynamic conditions with minimal endotropic support, and our scenario starts now.
Great job, doctors. We completed all 3 distal anastomosis without using cardiopulmonary bypass. Before looking at this heart, I was quite skeptical that we might need to go on cardiopulmonary bypass.
Excellent job, doctors.
All credit goes to her. She has managed this patient so well. Super.
So now it's time for the proximal aortic anastomosis. Are we ready for the partial aortic cross clamp?
Absolutely. Everything seems fine. Systolic BP is 100 mmHg. We are good to go.
Please keep the systolic blood pressure less than 100, as I can feel few plaques in the aorta.
Sure, sir.
What supports are going on?
Some low dose of noradrenaline, 0.05 mics per kg per minute.
So I'm cross clamp applied, I'm doing proximal.
Okay, everything is fine. Pressure is 92 mmHg. Good.
Proximal anastomosis done. I'm releasing cross clamp. Watch please.
Yes, watching.
Clamp released.
Sir.
Yeah.
BP is 80 by 42 mmHg.
Oh yeah, even PA pressures are also low. It is just 26 by 16 and CAP is of 7. That suggests patient is hypovolemic. Shreya gave 250 ml fluid bolus. I will do head low position.
Okay, sir. I'm also increasing noradrenaline to 0.1 microgram per kg per minute.
Yeah, that's well. That's fine.
Sir, BP is still not coming up. It is 72 by 32 mmHg.
Oh yeah, even SVRI is low. It's 1133. That suggests that patient is vasodilated. So Shreya start injection vasopressin 1.5 unit per hour. Increase noradrenaline to 0.1, 0.2 microgram per kg per minute.
Okay, sir, I'm starting vasopressin, but what could be the reason for patient being so vasodilated right now?
I think it could be because of levosimendan. Preoperatively, this patient was on levosimendan. Levosimendan is a profound inodilator.
Okay.
In few cases, it can cause severe hypotension because of vasoplasia. And even our patient is 77 years old, so old age patient have some autonomic dysfunction, and that is adding up into the problem of the vasodilatation.
Okay, sir. Then I'm also sending one ABG and ordering for one PRBC as there is significant blood loss on the field.
Oh yeah, there is a blood loss. It's good idea to order PRBC.
Doctors, heart contractility seems decreasing.
Oh yeah, even BP is also low. It's just 70/30 and cardiac index is just 1.4. Shreya, we have given fluids, we have started vasopressin, we have increased the dose of noradrenaline. Still, patient is not responding. It seems like the mechanical issue. Get the TE fast and start adrenaline 0.1 microgram per kg per minute.
Okay, sir. I'm also increasing NORAD to 0.3 and vaso to 2.4.
Yeah, that's appropriate. I got the TE machine. I am inserting TE probe.
Sir, we have received the ABG report.
Okay.
HB is 6.8, calcium is 0.99. Rest everything seems to be within the acceptable range. So I'm transfusing 1 unit of PRBC and giving 1 calcium gluconate.
Yeah, that's good. That's fine. Oh, BP is just 60/30 and cardiac index is 1.2. Shreya, give 1 milligram of bolus and I can see the transfusive echocardiography now. EF is just 15 to 20%, moderately severe MR. Oh, I can see a flap in ascending aorta.
Oh, you mean aortic dissection?
Oh, yes, doctor, there is acute aortic dissection. Look at the echo. I can see dissection flap starting from the right coronary ostium, extending up to the descending aorta. We need to fix this as soon as possible. We need to go on urgently on CPB. Shreya, give 10,000 units of heparin straight away.
Yes, sir.
Lisa, you please prepare the right groin area. We need to go on CPB as soon as possible. I will cannulate the right femoral artery for the arterial cannulation and the right atrium for the venous cannulation.
Oh, yes, patient is crashing. BP is just 55. Doctor, give internal cardiac massage. Shreya, give 1 milligram of adrenaline bolus.
Yes, sir.
Disha, you please continue with the internal cardiac massage.
Yes, sir, massaging.
Oh, Disha, you are doing excellent job with your massage. Now systolic BP is 85. Please continue doing massage. Doctor, we need to go on CPB urgently and we have to fix this dissection.
So this is the femoral cannula inserted and venous cannula in the right atrium. What's the ACT?
502 seconds, sir.
Okay, go on bypass. So this is the dissection flap in the ascending aorta. I have to replace this ascending aorta with the 30 mm interposition graft. So this is the proximal anastomosis was done and this is the final result. Everything looks fine, not much bleeding.
Excellent job, doctor. Excellent job.
I just need to do one radial arterial proximal anastomosis over that conduit and then we can try to wean from CPB.
Okay, yes, that's a good job. And right now there is no rhythm. We need to start the AV sequential pacing at the pacemaker box. I am starting AV sequential pacing at 90 beats per minute. And if you look at the T, EF is 20 to 25%, not much MR. There is no air in the heart and BP looks stable, normal PA pressures, cardiac index is fine. We are good to go off CPB. Perfusionist, please fill the heart gradually and come off CPB.
What supports are going on?
Dobutamine 7.5 microgram per kg per minute, NORAD 0.1 and vasopressin 1 unit per hour.
That's great.
Patient is vitally stable at present.
Great.
So we have successfully done coronary artery bypass grafting with ascending aorta replacement as there was acute aortic dissection in our case, and we extubated this patient the next day. All the vasopressors and inotropes tapered off by day 3. Patient shifted to room on day 5 and we successfully discharged this patient on day 8. Learning objective from our case is unexplained refractory hypotension during cardiac or non-cardiac surgery is not uncommon. And whenever there is hypotension, we have to act very quickly because hypotension itself sets a vicious cycle. hypotension decreases the coronary perfusion pressure, that further decreases the myocardial contractility, that decreases the stroke volume, decreases the cardiac output, and that further causes hypotension. So hypotension is a vicious cycle, and whenever there is hypotension, we have to go strategically, and we should have some algorithm, and we have to look for the cause, what is the cause for the hypotension, and whenever there is hypotension, we should categorize the cause in 5 headings, that it can be preload related, afterload related, contractility related, or it can be mechanical or rhythm related. So preload related issue most commonly because of significant blood loss or significant third space loss during the surgery. It can be relatively preload deficiency because of relative hypovolemia, because of vasodilatation. Afterload related causes will be because of vasoplasia or inflammation due to CPB, or it can be protamine reaction, or some drugs like levosimendan. In our case, it can cause profound vasodilatation and vasoplasia. Even AC inhibitors, ARBs can cause the intraoperative vasodilatation. Contractility related issues more commonly is the perioperative ischemia or infarction, or it can be air in the coronaries, post-cardiotomy stunning of the myocardium. If patient is on preoperatively high dose beta blockers or amiodarone. Mechanical issues like there can be tension pneumothorax, there can be cardiac tamponade, massive pulmonary embolism, aortic dissection, or it can be acute valvular dysfunction and new development of MR. There can be rhythm related, there can be severe bradycardia or tachyarrhythmias like ventricular tachycardia, ventricular fibrillation. So whenever there is hypotension, systematically we should look for the cause and we should act early. And TE is one of the best tools to diagnose the cause for hypotension, because with TE, we can have real-time visualization of the heart, and we can differentiate whether it's a problem with the preload, or whether the problem is the contractility, or is there some mechanical issue like in our case. So within seconds when we insert the TE, we can have the idea what is the cause, and we can treat that in timely manner. So TE is not just a monitor, but it converts hypotension from a number problem into the cause-based diagnosis. And with use of TE, we can avoid the blindly escalation of the inotropes. Like for example, in our case, if we would have blindly gone on adrenaline, noradrenaline, that would have extended our aortic dissection flap and further harmed the patient. So with TE, we know what is the problem and we treated it. So TE is one of the best monitor in crisis management. And with this, our case, we also want to emphasize the importance of preoperative optimization. As we optimize this patient preoperatively for 4 days with dobutamine followed by levosimendan, we could do all the 3 distal anastomosis of cardiopulmonary bypass. When we have to go on the cardiopulmonary bypass, when there was aortic dissection, we could easily separate the patient from the CPB because we optimized that patient well. We didn't require the IABP, we didn't require the renal replacement therapy. We can extubate the patient the next day. We have also tapered off inotropes by day 3, and we discharge this patient on the 8th post-operative day. So this all become possible because of we pre-operatively optimize the patient well. So success of any surgery, whether it's a cardiac or non-cardiac surgery, depends on how well we optimize that patient for the surgery. So our take-home message is hypotension is common, and every anesthetist in their life face the problem of acute refractory unexplained hypotension. And whenever there is hypotension, we should always look for the cause systematically, find out it early before it's a vicious cycle, and treat it early. And TE is one of the best monitor in the crisis to look for the cause for the hypotension, and preoperative optimization decrease the perioperative morbidity and mortality. With this, we want to rest our case, and thank you very much.
Congratulations, Marenko, India.
Thank you.
Please come up to this zone, please. This scenario is happening in the well-equipped, full hemodynamics, unstable intubate, but full equipment, and ready for the cardiopulmonary bypass as well. Today, we have very well-known hemodynamic speaker, Lawrence Freiberg, and a lot of the judges. Could you please comment for our scenario? And in the same time, 5 minutes, we will have the transitions of the next team, and we have only 5-minute discussion to go to the next. And we already do the lucky draw for the sequence of the team, first, second, third, like that. Okay, please comment from just please. Yes.
Thank you. So it's a very interesting case. Whenever we do cardiac surgery, so whenever the aorta is being manipulated, we always have to check for possible aortic dissection. So my first question is, since you already had TE, why didn't you have the TE from the start of the surgery? Because whenever we do the clamp or do cannulation in the aorta, we always check for possible dissection proactively. And my second question is, you mentioned about the possibility of the residual effect of levosimendan on low SVRI, but you had no problem after induction of anesthesia until declamping. So why was there any further suspicion of levosimendan-induced low SVRI?
Yeah, so first question to answer, you have very rightly said TE should be there in each and every patient, but we are from the India is a resource limited country. We have 4 operation theater and we have only 1 TE probe. So generally on all patients who are already like on CPB going to like valve replacement or valve repair, we use TE probe and machine for that patient. Because we only have 1, so we can't help with that. It was in other patient when we induce this patient. So whenever there is crisis, we can get that TE probe immediately and we can do this crisis management. But I am completely agree with you. There should be TE for all the patient, but as developing country, we don't have that luxury. Thank you very much for this question. And to answer your second question, levosimendan can cause vasodilatation, even vasoplasia also. So initially when there was aortic dissection related hypotension, we were not aware until we put the TE. So it was just guessing that this low SVRI could be because of levosimendan and this hypotension could be because of levosimendan. And that is why we want to emphasize that when we don't have TE and just hemodynamics, it can at times mislead us. So that is what we wanted to present. We thought it's because of hypovolemia first. We gave fluid because PA pressure CP was low. Then we thought SVRI low is because of vasodilatation is hypotension. When we put T, then only we came to know it's because of mechanical issue of acute aortic dissection. So that is how it went. Thank you.
Wonderful case. Just want to clarify, you need to mobilize your resources to pre-optimize this patient before the surgery, and then you had inadvertent aortic dissection. This gentleman went for CABG plus a Bental operation. Why was the post-operative care only very transient in the intensive care? Do you expecting that the recovery of the left ventricle tremendously improved within 24-48 hours? Or what was your reasoning behind that? Thank you.
So very good question, sir. So because we optimize this patient well, and this is most of our protocol that whenever we get pre-operatively patient with 20 to 25% ejection fraction, with this congestive patient where PA pressures are 70, 75, cardiac index is low. So we optimize them well pre-operatively with dobutamine or levosimendan. Even at times we start milrinone also for this patient. So in our experience, when we optimize this patient well, post-operatively they behave very well, and generally most of the patient will be shifted to room in 3 or 4th post-operative day. So I think it is because of we optimize patient well pre-operatively, we could have better success in the post-operatively.
Congratulations, India. Let's move to the next team.
Thank you very much.
We will go to the next team. The representative of Thailand from boy band, the famous boy band of Thailand as well.
I am Dr. Jenipat Impongkat. I am Dr. Saranyu Lontiera and Dr. Chanapat Saransuk. And Dr. Virapong Samsuk. We are KKU team from the Department of Anesthesiology, Faculty of Medicine, Bangkok University.
Good afternoon, Chairman, Justice, and all team from around the world, and everyone here in this room and in the internet. So as a representative of an AACAwill team, we would like to say that it's an honor that we have to participate in this event, and we like to share our learning with all of you. So, thank you so much. Our case begins in Srinagar Hospital at Khon Kaen. And, you know, it's just everything seemed ordinary in the operating room number 7. And, you know, but in anesthesia, even on ordinary days, everything can change. So let's see what will happen.
Okay, so good afternoon, everyone. Before we start the case, let's do some briefing.
Okay. Dr. Ben, the patient is a 50-year-old man, body weight 60 kilograms. He is undergoing the extraction of the infected impact medulla molar and general anesthesia.
Okay.
He was no significant past medical history and no sign of upper airway obstruction. But his jaw is quite stiff due to pain, and the lab is unremarkable.
Okay, he has a little bit of mandibular swelling here. Sir, could you please open your mouth as wide as you can, please? Okay. I think the mouth opening is still enough for laryngoscopic blade
Do you
insertion.
think should we proceed with the awake intubation?
I do not think so because he still do not have any sign of upper airway obstruction. But anyway, nurse, could you prepare for the difficult airway equipment? Prepare the fiber scope, laryngeal mask airway, and elastic gum bougie.
Okay, all are available and already checked here.
Yeah. Okay, yeah. So, should we start the case?
Okay. Mr. This is an oxygen. Please take a deep breath.
Okay, please take a very deep breath. Nurse, could you give the following medications?
Okay.
Okay, so start with 100 microgram of fentanyl.
Okay, 100 microgram of fentanyl in.
Okay, next, please give 150 milligram of propofol.
150 milligram of propofol in.
Okay, sir. Take a deep breath. You're gonna feel a little bit pain in your veins, okay? Deep breath. Yes.
Okay,
This is sleep, sir. Next, would you try mass ventilation? Okay. Yeah, the chest is moving. Cool. So, nurse, could you give 100 milligram of succinylcholine?
Okay, 100 milligram of succinylcholine in.
Okay. So now let's just wait until the fast circulation is over. Then you gotta do the intubation.
Okay, I think fast circulation is over, doctor.
Yeah. Okay.
Oh, his jaw is more stiff. Is it the masseter spasm, right? Can you confirm this?
Yeah, I agree. His masseter is very stiff, but the mouth opening is still fine.
Can I try the video laryngoscope?
Sure. Okay. Let me help. Okay.
This intubation success?
Yeah, it's in. I'm taking the stylet off. Get the cuff in and connect to ventilator.
Okay, equal bed sound.
The chest is moving.
Dr. Ben, I will give the 8 milligram of cis-acetylcholine.
Perfect, thank you. And the antidote CO2 is continuously rising. I'll get the sevoflurane on to 2.5%. Adjust the ventilator.
Oh, Dr. Ben, the antidote carbon dioxide rapid rising. And he still have the masseter muscle spasm.
Oh, yeah, I agree. Should we check for the depth of anesthesia first?
Sevoflurane is on.
It's on and the end-tidal concentration is 2%. Nurse, have you given the systematically?
Yes, it's already given.
Yeah.
Do you want to check the temperature?
Oh yeah, please get the temperature.
Okay. It can be a sepsis, doctor.
I think the onset is very fast for sepsis. How about the early sign of malignant hyperthermia?
Oh, the temperature is 38.5 degrees Celsius.
Okay.
Can I turn off the first warmer?
Thank you very much, nurse.
It's like AMH.
Yeah, I think this could be a sign of malignant hypothermia.
Oh.
Could you immediately call Dr. Art for help and also for the MH kit?
Okay.
Okay.
Okay,
What should
Dr.
I do,
Art,
doctor?
please,
Yes,
I need your help at OR number 7 and take the malignant hyperthermia kits now.
Dr. Go now. Dr. Till, could you please place a large bore IV and an arterial line, please?
Okay.
I'll turn off
I will hold you.
sevoflull rain, increase the FiO2 to 100%, flush the circuit with a very high flow, increase minute ventilation.
Dr. Ben, I will switch to the Papa 40 IBA.
Perfect. Please start with 2.5 nanogram per milliliter.
Okay.
Okay.
Okay, the arterial side is success.
Perfect.
Before it's accurate to the patient.
I see.
Oh, EKG check.
Yeah, I think we have ventricular tachycardia now. Palpate for the pulse. So,
pulse is full.
Yeah, we got the bounding pulse. So it's going to be VT with the pulse according to the guideline. We should start with amiodarone.
Okay.
Nurse, could you get it?
Okay.
Do you want a defibrillator?
Yeah, prepare defibrillator
I
as
will
well.
prepare it.
So please give me 150 milligram of amiodarone and give it to me, please.
150 milligram of amiodarone is ready.
Okay, defibrillator, doctor.
Okay. I will give 150 milligram of amiodarone.
Okay.
Okay.
I will record it.
Yeah.
Okay,
so
Dr.
150 milligram of amiodarone in. Okay, Dr. Art. Okay, we have a case of almost certain malignant hyperthermia situation according to the diagnosis guideline.
Okay. So do you think you need dantrolene now?
Yeah.
Yeah, and what the patient weight?
The patient weight is 60 kilogram. The initial dose gonna be 2.5 milligram per kilo.
Okay, so
we need 150 milligram of dantrolene.
150. So we need 8 vials of dantrolene.
Dr. Ben, can I put the co-pack?
Sure. Let's start the active cooling. Please place the cold pack at both neck, both axilla, and both groin.
Okay, got it.
Also, nurse, after you place the cold pack, please take the cold IV fluid.
Okay.
Cold saline for 2 liters.
Got it.
Free flow to the last vein.
Okay.
Cold saline. Okay. And Dr. Tube, could you draw the arterial blood gas for analysis as well?
Okay.
Okay. Thank you.
Saline is ready.
Okay, perfect. So if anyone in the team, if you see any worsen, any improvement, say it out so that we all know.
Okay.
Okay. Okay.
Wait a second.
Okay. So the cold saline start.
Okay.
And we
Now
start
we
the active
start.
cooling already.
Yep.
The blood gas is also pending. Okay.
Okay, the dantrolene is ready.
Okay.
So I will give dantrolene 150 milligrams, right?
Okay, please follow us through that large vein.
Dantrolene 150 in.
Okay.
Okay, Dr. Ben, arterial blood gas report return. His arterial blood gas show the severe metabolic acidosis and hyperkalemia and hypercapnia. Potassium is 6.2.
Okay, so we have a severe acidosis and also hyperkalemia.
Okay, I will increase the minute ventilation.
Thank you. Dr. Art, could you please prepare 7.5% sodium bicarbonate for 100 milliliters.
Okay.
And also 10% calcium gluconate, 10 milliliters.
Okay.
And 10 units of regular insulin for IV bolus to correct the hyperkalemia as well as the acidosis. Okay. Nurse, did you catch up that?
Okay.
Okay.
I will cut off.
Yeah.
I need 10 ml syringe.
Okay.
Thank you.
Yeah.
I will help you.
Okay.
Okay.
Check it.
So, bicarb in.
Bicarb in.
Okay, Dr. Janipat, during we are waiting for the clinical
in.
improvement, I would like to follow our institute
Liquid
protocol.
insulin in.
I'd like to check that everything complete.
Okay.
So you have health, you have MS kits, and you have turn off inhalation agent, right?
Here, checked, sevofluorine off.
Okay, and you administer 100% oxygen, right?
Yeah, right.
Okay, and you have airlight and arterial bus gas.
Yeah, sure.
And you treat hyperthermia, hyperkalemia, and acidosis,
Okay,
right?
sure.
Okay, and you give 150 milligram of dantrolene for the first dose.
Sure.
Okay, so let's see how the
Okay.
patient improves.
Please let me know if I miss anything. Okay, is there any improvement after the initial dose of dantrolene?
I think
let's
he
check.
still have the muscle rigidity, Dr. Ben.
I agree. I think he still has a very rigid muscle. So, and the vital signs are still very, very viable. So, should we repeat the second dose of dantrolene bolus?
Okay, I agree.
Okay, so it's going to be 2.5 milligram per kilo equal to 150 milligram again.
Okay, I see.
Do you need a Foley catheter?
Yeah, sure, it would be very nice.
Okay.
We need to keep high urine output as well. Okay, the Foley is on.
Yes, the Foley catheter is in place.
What's the color of the urine? It's still yellow?
Yes, still
Okay.
yellow is about 50 millimeters.
Yeah. So after the first one finished, the course line, give the second one.
Okay.
Okay.
I will change.
Okay. And after we give the second dose of dantrolene, draw arterial blood test.
Okay.
Yeah.
Okay. The second dose of dantrolene is ready.
Okay, let's give it.
Excuse
So,
me.
150 milligram of dantrolene for the second time.
Yep. Second dose dantrolene.
Yeah. Yes, please get the
Okay.
record on.
Okay.
Okay.
Okay, I
All
will
in.
draw the blood gas.
Okay, perfect. So now let's re-evaluate the patient for any improvement.
Okay.
I think we starting to have an improvement. Yeah.
Dr. Ben, do you want to remove the cold pack because the temperature is normal?
Okay, it's below 38, so please remove the cold packs and
Okay.
stop the active cooling
Okay.
as well.
Okay.
Okay.
The Pascal report the pH and potassium level return to normal.
I see.
But he still have high carbon dioxide.
Okay, sounds better. Dr. Art, could you please arrange for post-operative ICU?
Okay.
As well as contact the surgeon and the relatives as well.
Okay. Okay. Wait a second.
Yeah. Okay, I think for the minute ventilations, we have to wait a little bit more for the CO2 to be washed out.
Okay.
Now I think we have stabilized the patient quite very well.
Okay.
Yeah.
Okay, the ICU is ready, and the surgeon was agreed to postpone the surgery.
Okay.
And I have to tell you that we only have 5 left of dantrolene. We have only 5 vials of dantrolene left.
Okay.
But we need 12 vials of dantrolene for maintenance in the ICU.
I see.
So just follow the AACA guideline. I would like to call the nearest hospital that
okay.
have dantrolene for more additional
Yeah,
dantrolene.
let's call our neighbor. Okay.
Okay.
So thank you so much everyone for your contribution to this case. Let's monitor this patient until we send him to the ICU.
Yeah, but
what a wonderful management of the KKU. One of the most dangerous complications that we don't want to meet this complication at all. And this complication can happen anywhere all around the world, right? Please. I would like to have the comment from Dr. Wayne Morris about the management of this one.
Congratulations to the KKU team. That was a really well structured scenario, clearly demonstrated with lots of good learning points. I particularly like the way you demonstrated the use of the MH protocol checklist, because it is quite a complicated scenario, so a checklist is very helpful. Just one question. Drawing up the required dose of dantrolene can take quite a lot of time. So in your hospital, how would you manage that in a real life situation?
For this question, I would like to ask, I wanted to share our experience in the 2 days ago. We have just faced the MH in the real life, and because our hospital has dantrolene stock, about 20 vials of dantrolene in the supply in the operation room. So in that case, the patient can receive the dantrolene within 10 minutes after the diagnosis. Yep. So we don't have to take time too much to take that.
Just a follow-up comment. In our MH protocol, we would probably allocate 2 or 3 people to organise the dantrolene and draw it up. So it's just the comment that it can take time to draw it up, and sometimes you need an extra person. Thank you.
Thank you.
Thank you very much.
Dr. Jack Kwang-Ching, please.
I have a question regarding the use of amiodarone. So you had a pre-tech, but it was with pulse and hemodynamic instability was not evident, and pre-tech may have been most likely because of hyperkalemia and also partly from fever, but respiratory acidosis. There was anti-CO2 was like over 90. So what was the reason of choosing amiodarone? Because you may have used lidocaine, and then when it stopped, maybe given calcium gluconate and try to lower the potassium maybe. So was there any specific reason to use amiodarone, which requires like 15 minutes of infusion?
Okay, so at the moment that the ventricular tachycardia happened, we still didn't have any evidence of hyperkalemia because we just placed an arterial line without analyzing the arterial blood gas. But according to the European guideline for malignant hyperthermia, tachyarrhythmia is very, very commonly happen in those with very fulminant MH. So according to the guideline, they suggest that we use amiodarone first for tachyarrhythmia.
Yes, the comment from Nepal. Dr. Biswas, please.
Thank you very much. It was very nice demonstration, good team effort, good communication skill. And you didn't forget to put the Foley's catheter at the end. But would you go with the irrigation with the cold saline from Foley's as well, and Yenzi's nasogastric tube if the temperature keeps on rising? What's your choice? To cool the temperature.
Yeah, so
Foley's catheter was basically to check the output, I guess. Right, but you can.
So I agree that the cold saline irrigation through the Foley catheter would be one of the active cooling
and the
method. Yeah, and the NG as well. But as you can see that we have very, very limited personnel and also very, very limited resources and someone to help. So we mostly focus on the management of NHS as well, and we also did the active cooling by placing the cold packs and as well as the cold saline and stop the forced warming and everything that we could do at that time.
Yeah, thank you. Thanks for nice management. Thank you.
Thank you very much.
Thank you very much, KKU, the wonderful boy band of Thailand.
Thank you.
Thank you very much.
Yes. Next, we have another team from Thailand. Please welcome Sirat Hospital.
One of the biggest hospitals in Thailand.
Sierra, safe and sound. Anesthesia for every life, safe and sound.
Okay, welcome to the OR. My name is Jason. I'm the general surgeon. This is my scrub, Kate. We have our circulating nurse, Pat. Our anesthesia team today is Dr. Rachel and Nick. We are undergoing a liver transplant surgery. This is a 60-year-old male patient. He has hepatic cirrhosis preoperatively complicated by mild to moderate portal pulmonary hypertension. His mean PA pressure was 32 on the echo. We are approaching a very critical step in our surgery, that is the reperfusion of the hepatic donor graft, and I'm going to release the portal vein clamp. Okay, okay, Rachel, I'm done with the IVC anastomosis. We did a piggyback technique. Everything looks fine. Let's say 2 minutes for unclamping. Sounds good to you?
Yeah, sounds good. Okay, thanks for the heads up, Jason. So, Nick, you want to get ready for reperfusion?
Yes, I'm
okay,
ready.
Kate, can you help me with the unclamping process, please?
Okay, I'm ready.
Yeah.
Yes, here is the last blood gas. Everything is pretty good. And right now we are running on the vasopressin at 0.04 unit per minute. I have the EP ready to go. I have calcium and bicarb. I have the bolus set of the EP, EP, ephedrine, and atropine ready. And right now the patient blood pressure is okay. All parameters are good. I think we are ready.
Okay, so pressures look pretty solid there. Blood gas is good. And Pat, I'm going to need you to get us 4 units of blood to be ready in the room for reperfusion.
Sure.
Okay.
I will check it and take it to you.
Yeah, and then I'm going to increase the FiO2 to 100 here. I'm also increasing the ventilation here. I'm coming down the gas as well for reperfusion. And pressure still looks good there, Nick, yes?
Okay, yeah.
And you have some boluses of pressors ready to go?
Yeah,
okay, perfect, in your hands, yes? All right, Jason, I think we look pretty good here. Everything is solid. So if you want to do the reperfusion.
Yeah, I'll do the unclamping of the portal vein now. Okay, Kate, can you help me check with the bleeding, please?
Okay.
Right.
The portal vein is unclamped. Oh, I have a bit of bleeding here, but I think it's okay. Now the blood pressure is down, 60.
Okay, well, we're not doing that great. You started with the vaso just now.
Okay.
Can you go up on the vaso, and then we will need to go up on the norepi as well. Start the norepi now.
Okay.
Okay.
Right now.
You have some boluses here. Just give like 8 mites of norepi or something.
Okay.
Yeah. And
Rachel,
how's the patient doing?
Have a look at the CVP right now.
Yeah.
I think the patient had a pure pulmonary hypertension. Right now we are looking at the high CVP, high PA, and also low CI. Do you think there could be a problem with the right heart or pulmonary circulation?
Oh, yeah, thanks for bringing that up. Especially the patient also had pre-op portal pulmonary hypertension, but it could be a problem with the left heart for all we know because
Are you looking at the VP?
I am. Yes, definitely
it's like
we
60.
are.
The VP
Yeah.
is tanking.
We
CV is gone up the roof. We're not going to survive with that CV, okay?
Totally
and you're
fair.
talking to your fellow. You're not fixing my patient.
I am actually actively managing here, Jason. Actually, my fellow here.
I mean, you have to do something.
Exactly, that's what we're doing. We're putting in TEE, correct? Yes?
Yes.
Okay, so my fellow is going to put it in TEE.
Okay.
And if you can help us, I think you can you reclaim the portal vein for us, please?
I could, but I don't want to. I mean, it's going to prolong the surgery. The valves will get more congested. And I'm sure you can do something else rather than I'm putting on the back on the clamp.
And I understand your concern, and it's very valid. But the priority right now is that the patient is tanking, and we've done everything that we can. He's on epi infusion, he's on norepi, he's on vaso. We already gave him some boluses of norepi and epi as well, and he's not responding at all. We're looking into the cause of this, okay? So if you can buy us time, can you reclaim the portal vein for us,
I mean,
please?
I'm having trouble understanding what's happening, and I don't know what you're doing.
Okay, what's happening is the patient is not doing well, and you can help us if you can reclaim the portal vein. Please, Jason.
Right, okay, I will try to partially clamp the portal vein, but I'm not going to waste time on this clamp,
amazing.
right? Just hurry up.
Yep, and we'll keep you updated, okay?
Yes. Rachel, could you please take a look at the RV for me, please? So right now, I'm at the mid-esophageal for chamber view right now. The RV is dilated, and after the color Doppler on, I see some TR as well. I think RV is not good.
All right, agree. Can you show me the left ventricle too?
For the left ventricle, I think it's a little bit underfilled. Anyway, no dynamic airway obstruction and no air thrombus in the heart on the PA.
All right, perfect. So Jason, Nick just identified an RV failure on the echo here. I think that we are looking at a severe vasoplegia from the reperfusion, and he had a pulmonary hypertension in the pre-op, so probably that triggered a pulmonary hypertensive crisis. So what we're doing now, we're supporting the pressures of the RV, and then I'm going to ask Pat to check the blood gas for us, see if there's anything that we need to correct.
The BP's gone up.
The PP,
I can take the climb up now.
has gone up because you help us reclamp the portal vein, but we still have things to do here, okay? So let's check the blood gas here. All right, so pH 0.28, not that great. Hyperkalemia, hypocalcemia. Hemoglobin is 8, so that's, acidosis and hyperkalemia. That's consistent with reperfusion injury. So I'm just going to correct the labs here. Nick, can you take care of the pressors?
Yes.
All right, so I have some...
I'm waiting on you. Right?
Okay, yeah.
Tell me when you're
100%.
ready.
For sure, yeah.
Yes.
So we are giving insulin here.
Right now, here.
Okay. Yeah.
Okay. I think we are running a vasopressin and now EP right now.
Yeah.
I think that should help the vasopressia.
Okay.
And we are already at the epinephrine at 0.1 to support the RV perfusion.
Yeah.
Yes, and for the ventilation, I think it's not good at all, so I will increase the minute ventilation and optimize the PEEP a bit.
Okay,
so
thank you,
after
Nick.
this, we should check how it responds.
Okay, and I just corrected the labs. I just gave them bicarb, some insulin and dextrose. Just to let you know though, Jason, if the patient is still not doing well, we probably need to consider
I mean,
like
he's
an
doing
ECMO
well
or
now,
something.
right? Yeah.
Yeah, we'll check the blood gas. Nick, can you check the right ventricle again?
Okay. I think the RV is better. RV feeling is also improved.
Okay.
Okay, yeah, just waiting for Pat to come back with the blood gas.
We have ABG.
All right, okay, the new blood gas is pretty good. So no more hyperkalemia. Calcium is good. Hemoglobin is good. We just did give a unit of blood. I think the pressure looks pretty solid now. Jason, if you want to do release of portal vein slowly this time.
Yeah, I'm slowly releasing my portal vein. Okay. Kate, can you help me check with the bleeding too? Thank you.
Yeah. We have check bleeding here.
Okay. Portal vein is totally unclamped.
Yeah.
All right. Perfect.
Looking good for you?
Looking good on our ends. Pressure is good. Yeah, we'll try to come down on
Are
the
you happy?
pressures.
Are you happy?
Yeah, happy.
You too, Nick? You're happy too?
Everyone's happy, Jason.
Okay.
You can continue with what else do we need to do?
Just want to come down on the epi.
Yeah,
and
sure.
I'm going to proceed with the
Of
arterial
course,
anastomosis, all right?
So we're coming down on the epi.
Yeah, looking good.
I just turned it off. He's
Thank
just
you.
on a bit of vaso and norepi. So, okay, that was exciting, Nick. I'm having a hypoglycemic
Me too.
attack. Yeah, so I think we should get like bubble tea.
Sure,
Yeah?
why not?
Okay, we're putting an order for bubble tea. What do you want, Nick?
Can I have an iced matcha latte but with oat milk, please?
Oat
Oh,
milk.
milk.
Oh my
Fancy,
God,
Nick.
he's
Can I get one
fancy.
too?
eh?
Yes, thank you.
Okay, oat milk. Matcha?
Yeah.
What's that smoke coming from?
I don't see
Smoke?
anything.
I'm
That's-
sure it's
that's a
nothing,
smoke
Rich.
there.
It's just a cautery.
That's
This is
a
my
smoke.
cautery. Okay?
Oh, my country, yeah.
Kate, can you come down on cautery, please?
Okay,
the smoke is
no,
not.
I don't think
Anesthesia doesn't like
I
all
don't
the
think it is
smoke,
the cautery.
okay?
I never
It's just the
complained
cautery.
I never complained about the bovie. I think it is Pat.
It's my
guys,
body.
it's just the phone from the OR manager. She said upstairs is code red now.
Really?
Yeah.
Oh, there's a code red?
now.
What
Yeah.
should we do?
But the fire is our floor is
Right.
I don't know why.
Okay. Are you
sure?
Yeah.
Are you serious?
Because
Oh.
yeah.
Okay.
Lab is running.
I mean, I'm sure it's just a drill.
It is not a drill though, Jason.
Yeah,
Do you
I'm sure
see
it's
the
just a
smoke?
drill.
Okay.
Kate, can you tell him?
Yeah.
Okay, so what should I do?
Okay.
Evacuation.
Okay. The power is still okay.
Okay.
Jason, it's
Jason.
not a drill.
Jason, I can
Okay,
see
the
the
power
smoke.
is out. The power is out. It is not a
It
drill.
smells bad.
And I can hear my oxygen cylinder alarm. Like
What
the
do you need
oxygen
to pack
supply
your
is cut.
patient?
Okay.
Okay, I'm gonna
guys.
try and pack up the patient.
Nick, can you check the oxygen if it's
Okay.
working? Check the
Yes,
oxygen
the cylinder
cylinder.
is running right
Okay,
now.
perfect. And Pat, can you pull up the evacuation checklist?
Yeah.
And then can you make sure that we have safe evacuation route, please? Okay,
Sure.
perfect.
I will confirm with the OR manager. She said we have to go this route or connecting to the next building.
Okay.
Yeah.
Okay, perfect. Okay, everyone stay calm. Listen to me, okay? I'm just gonna do a quick summary here. So we have a fire upstairs. It's in the same fire zone as our room here. We have a power cut. I don't have oxygen. We're running off of the oxygen in the tank here. We have about 5 minutes to move the patient to the other OR. Okay, and then we need to be systematic here. So Jason and Kate, you're gonna pack up the patient. Stop the bleeding, pack up the patient, staple. Me and Nick, we're gonna prepare everything for transfer, and Pat, you're gonna help us, okay?
Yeah.
So first, Nick, can you check if the power outlets are out too?
Yes, emergency outlets are out, so everything is currently running on the battery. The CTE is not working, but monitor is still working. We can just take the transport monitor with us.
Okay, and you can take the TE out if it's not working.
Sorry for interruption, but do you think it's safe to move the patient like this? I think we should wait for someone else to come and help.
The pressure is not, it's fine. And it's not safe to be here. We are told to
I'm
evacuate
still
in
working
5
on some
minutes.
bleeding here.
Yeah, for sure. That's what you should be doing right now. Yes, exactly. And so we check the oxygen, and so the oxygen tank that you checked just now.
Yeah, we'll check.
Is it going to be full for is it full? Are we okay?
Yes.
Yeah, it's full. Okay. But Pat, I'm gonna need you to bring an extra oxygen cylinder as well for transport. Okay.
Yeah, being full oxygen
All right.
tank and getting transport ventilator.
Perfect. Amazing. And before you go, can you
yes,
also?
Kate, you can scrub out and
Oh,
help them.
sorry for this.
Thank you so much. Okay, if you're
we running out of time.
Okay.
We have to go by OR bed.
Can we have a stretcher?
Yeah, sure.
No one has a stretcher for us?
No stretcher now.
Has anyone ever transported with
God.
this bed?
I never, but
I mean,
I think
it's
we
your
should
call,
go.
Rach. I don't know. It's your call.
All right.
Tell me what to do.
Yeah, I think
your call.
Can I hear you? Can I
We're
hear
going
you?
with the OR bed. Everyone,
Please check the transport.
I need
Okay.
the room quiet, okay? I need the room
Okay.
quiet. I need the room quiet. We're going with this stretcher, okay? And then me and Nick, we're gonna prepare the drugs. And then Kate and Pat, you see the checklist?
Oh, yeah, sure.
Yes. Here. The checklist, okay? Just prepare the equipment in the checklist.
Okay. So currently the patient is on the EP, now EP, and we are suppressing now. Viewing the calcium and bicarb with the patient. Here.
All right, perfect. And then on the checklist here, it says we should bring
Yeah.
the DAS here, some
Okay.
rock, boluses of norepi. You have
Yeah.
that there.
Yeah,
ephedrine
just-
and atropine,
I have already
some
started
epinephrine there.
proper formation.
And then all the
Yes.
equipments are ready. Some ambu,
Yes.
oral airway LMA.
Yeah,
all those things.
in this
Okay.
bag.
Yeah.
Perfect. And Jason, you're okay
Yep.
there?
I
Yes.
mean,
Are you
I
done?
think we should move.
okay.
All right. Okay.
Let's say we move
if-
now.
Okay.
Yeah. Okay. Kate, can you attach the monitors on the patient, and then we'll do the ventilation with Nick.
But you're sure the BP is okay, right? But you're sure we're good?
Yeah, the BP is fine for now. Okay.
Yeah.
We're
Okay.
doing the best that we can.
Okay.
So Nick, you want to be careful with the setting
Yes,
as well,
I will
because he
strain,
just
right?
had an RV failure. I don't want to strain the RV too
Okay.
much. Okay.
Yeah, don't
So-
get the CVP up. I want a CVP very low.
Okay, so
yeah.
the
Yeah.
CVP we cannot take, right?
Okay, right.
We need to minimize
Now we have
the
2
monitors.
minutes.
Okay, we
Yeah.
have 2 minutes. Okay. All right, so we'll distribute the task. I'll be
Okay.
the one doing the air. I'll be the one doing airway. Okay?
Okay.
And then you will take care of the hemodynamics.
Okay.
You two push the bed, and then can you
Okay.
take care of the IV pole?
Sure. Okay.
Okay. And then I'm gonna call them to let them know that we're
Okay.
coming. Okay?
Okay.
Yeah. All right. So on my count, everyone will push. Okay? 1,
Okay.
2, 3. Push.
Yeah. Please be careful. Yeah.
Oh, please be
please
careful.
Oh,
Oh, no.
Okay.
Please wait.
Okay.
Okay.
Dr. Rachel, the patient blood pressure is dripping down so rapidly.
Okay.
Yeah.
Yeah, but I think the pressure are running fine. Nothing
Yeah?
disconnected.
Okay. So what do you think it is? Could it be the RV again? I disconnected.
I do a few podcasts here. I have a portable ultrasound with me.
I don't think it's safe though. Yeah,
okay.
just
That-
go.
that makes sense.
Just
almost
give
there,
him some
almost there.
fluids
Be
or something.
careful.
Are we at the safe spot?
Yeah.
Okay.
Yeah,
okay.
Yeah, we are at the
Okay,
same
Nick,
spot.
you can do the podcast. You can do the podcast all you
Okay.
want. We need some directions
So
moving
tired.
forward.
Yes, yeah. Okay.
Okay,
So the
focus.
yes.
Yeah.
The heart pumping is okay, but look empty. And
Alright.
hyperdynamic, I think we should increase the fluid.
Okay, perfect. Let's do that.
Okay,
give some
I will
fluids.
do that.
Okay.
Oh
Uh,
gosh.
I mean,
all right.
Yeah, you're very good with on your end. I have a little bleeding. I mean,
Really?
Wow.
I think
It's not. Like,
I will
just give him
put
2
a
units
little
of blood.
bleeding here.
Just give him 2 units of blood.
Okay, 2 units.
Okay?
Right. Okay,
yeah.
just a tiny bit. I'm good.
Okay.
Yeah, it's controlled.
Thank you so much. Have a round of applause of Sirius Hospital team.
Hello, this is your rider. Your bubble tea is
Okay,
here.
I hope the patient is safe after a lot of the fire in the hospital. So please welcome Sirius team over here. We have 5 minutes for the judge, please. Okay, good. You can move forward while the backup team try to take the table, operating table back to the scene, okay? Okay.
But I want my bubble tea is like here.
Right, we will give you later on.
No, we have the bubble tea. Where's my bubble tea? Oh.
Okay, don't worry about bubble tea. So, yes, the team come here, and I would like the judge to make any comments or any questions, please.
Excellent double crisis management, team Sriraj. And Jason being the real surgeon all the time. I had one question to the team. That what is your standard reperfusion crisis management protocol in your hospital?
Oh, okay. So during reperfusion, so first of all, we don't actually put TEE in everyone because like we have limited amounts of TEE and like staff who do liver transplant and also do TEE. So we use it kind of as a rescue. The standard protocol is that the patient has to be stable. Usually we treated the MAP to about 85 to 100 as a pre-treatment for reperfusion. And then we check that the blood gas has no hyperkalemia or at least has room for some hyperkalemia. Calcium is good, and then we have some blood products ready in the room in case like when it reperfuses and then the anastomosis is not great, something like that. And usually we time, so we kind of expect patients to be, going like not doing well within like the first 5 minutes, something like that. And after that we will run a rotem, and yeah, we just have like. Actually, to be honest, we don't actually have vaso in Thailand right now, so we use norepi. And then some staff use terifluoxetine. I don't know how to use that one, but so we use norepi. We also have like boluses of norepi, ephedrine, some boluses of bicarb and calcium ready. And then we follow the gas again and see what metabolic arrangements we need to correct.
And do you flush the system with the room temperature ring-lactate or a balanced solution?
You mean flush the liver?
Yeah, flush the liver.
We do with 5% albumin. We do like 1,000 cc's, and then they flush the liver. Yeah, and we keep the patient warm with upper body warmer. And now we just have an under body warmer, and then sometimes I turn on the lower body warmer as well, and I think it works pretty well.
Great, congratulations.
Thank you.
We still have time, please.
I think it's a very interesting case, and you managed it very well. And you also mentioned about limited resource regarding TE. So of course it would be great if you can monitor TE continuously, but one of the things what you did good was you looked at CVP and you scaled it small, so you can see the changes in CVP waveform. So whenever after reperfusion, when there was a significant RV dysfunction like that and you had severe tricuspid regurgitation, before even you see the TE, you can see the changes in the CVP waveform of peaking off during the systole, like the ones you showed. So your monitor already displayed the changes in CVP waveform, so you can immediately suspect, oh, there's something wrong with my RV, at least severe tricuspid regurgitation is happening. So I think it's good that you actually monitor the CVP waveform instead of just looking at the number, and it should be very useful when you don't have TE readily available.
Thank you.
Congratulations, Team Suriraj. That was a very complicated scenario, but the standout learning points for me related to communication, and I think especially the communication from Rachel to Jason. It was, I think, an example of graded assertiveness. She was very clear, she was using names, so for me that was one of the most important learning points from this scenario, so congratulations.
Thank you.
Thank you. Thank you so much, Siraj.
Yeah, one request to Kate. Can you show us how your suction works? Again. Yeah, in mic. Yeah,
thank you so much. Thank you. Thank you so much. Now we need to move to the last team of our first round. First round, 5 teams. Second round, another 5 teams. Now it's going to be Malaysian team.
Yes. Hi everyone, I'm Jennifer from Malaysia.
Hi, I'm Pei. I'm from Malaysia.
Hi everyone, my name is Ismail Khaldun and I'm from Malaysia.
Hi everyone, my name is Yo Jae Chong. I'm from Hospital Sungai Buloh, Malaysia.
No pain, no fear. NS is here. Malaysia, boleh!
Hi. Okay, first of all, good afternoon everyone. This is a long case today. It's the 5th case of the day. And I think all the anesthesiologists are very tired now. So let's start the case without any delay. So I just like to give we're going to start the scene by our briefing of our team. All right? So, hi, morning everyone. Morning Jennifer.
Good morning.
Morning Mr. Don. Yep. How are you?
Fine.
Good. Fine. Okay, so we're going to do a case of laparoscopic sleeve gastrectomy. And the patient is morbidly obese, all right, and also have obstructive sleep apnea. And we anticipated difficult airway during our pre-op assessment. And also, just be aware that all the difficult airway trolleys is ready, the equipment, supraglottic airways, ETTs of different sizes, our front of neck access tube, all right, and also I want the fiber optic scope, all right. Okay, as per the DAS 2025, there's a lot of recommendation. We shall make full use of the guideline, okay. And remember our last case, Mr. Don?
What, yesterday?
Yes.
Bleeding?
Yes.
This one shouldn't be a bleed.
It won't bleed?
Laparoscopic.
You sure?
Simple.
Okay, I trust you.
Doctor, I have done the check-in. All the vitals are stable.
Very good.
Right now.
So we have put on all the standard monitoring already?
Which is here.
Okay.
And also I put on the temperature monitoring and
Okay.
pneumatic cuff.
Yes, madam. Hello, good morning. Remember when we saw you in the clinic, you refused for awake fiber optic? Can I just confirm with you one more time? Are you sure you do not want to allow us to do awake fiber optic for you?
No, doctor. I said I don't want already.
It's okay, don't worry. We always have this kind of scenario. We will do our best for you. Don't worry. Okay, Jennifer, we'll do a sleep intubation technique. Okay, so let's go with video laryngoscope straight away. No point we do direct laryngoscope. Okay? Let's go with video. And so, yes, we should ram the patient. Come on, I help you. Madam, can you please lift your head up a little bit? Ready? 1, 2, 3. Okay, very well. Yeah, so the tragus is in situ with the sternum. Very good. Yeah, okay. So before we start, yes, can we put on the high flow nasal cannula? Yes. DAS mentioned that we should do apneic pre-oxygenation, peri-intubation oxygenation. Right. Okay, so put on the high flow nasal cannula. Jennifer, this is a challenging case. Do you want to take up the challenge to get an IV line for this patient?
Yes, sure. Sorry, doctor, I have attempted twice, but I still cannot get. I can't
No
see
worries, no worries. As long as there's ultrasound, anything can be done. Come, let's get a line for me. Can I get the lines? All right. Okay, so let's have a look at the screen. Yeah, okay, nice line. Okay, in, done. Excellent. I mean, Jennifer, you're excellent.
I'm so sad.
Yeah, it's okay, don't worry. Come, let's pre-ox the patient. Can you pass me the face mask? 10 liter, FiO2 1.0. And we will give this for a good 3 minutes together with the high flow nasal cannula. Mr. Don. Get ready,
Okay, I'm here.
Yeah, great. Thank you very much. Okay, so madam, can you please breathe in and out. Again, in and out. Deep, deep breath. Very good. How is the ETO2?
It's around 89% now.
Yeah, okay. Okay, all right. Okay, deep breath. Okay, Jennifer, can you please administer the drugs? I would like IV fentanyl of 100 mics. Okay, propofol 200, succinylmetonium 150. All right.
Okay, IV fentanyl 100 mic, IV propofol.
Okay, hold on.
And IV succinylmetonium 150.
Yes. Madam, take a deep breath in and out. Madam? Okay, so come bring the video laryngoscope. Let's try. Oh, it's a little bit difficult.
Would you want me to apply some pressure over the...
Please. I still can't see anything. It's Pogo 0%. It's okay, don't worry. Come, let's go.
I would like to change to hyperangulated blade for
Yes,
you.
thank you very much. And also, this time we do fiber optic intubation. We call it FAVI. Video assisted flexible intubation. Can you please stand over this side for me?
Pass you the scope
Yeah,
first.
yes, thank you. Okay. Okay. Breathe in and out. Ready?
Okay.
Are you ready? Let's go. Okay, can you please hold the scope for me?
S6.
Hold the scope. Okay, very good.
I'm holding the scope now.
Oh, Mr. Don, you're very fast, huh? Hey, I have not secured the airway. You can continue. Okay.
Yes, the tube is in.
Wait, the tube is not in yet. Okay, done. Okay. See, I told you.
Yeah, excellent.
Okay. Okay, can you
Inflate
just
the
hold the scope
ETT.
for a while? Okay. Inflate.
Inflated.
Okay, bagging. Okay, just put the stuff at the side. Okay, let's auscultate it. Put on ventilation. Set. Okay, air entry is equal. Okay, so tape it. All right.
Now
So
the ETT is at 22 centimeter.
yes, Mr. Don, airway breathing. I have settled it. Where's my chair?
I am
yeah.
happy. Thank you very much.
Yeah, airway breathing and chair.
All right, inserting first spot.
Okay.
First spot, increasing pressure to 16, please.
16 now.
Yeah. All right, 16, very nice. Inflating very nicely.
Mr. Don, my pressure is coming up.
How much is the pressure right now?
20.
Oh, sorry. I'll reduce to 12, please.
Thank you.
Now at 12.
Okay, I'll insert another 2 pots. Reverse Trendelenburg, please.
Reverse Trendelenburg now.
Okay.
Mr. Don, can you let me sit? What is happening?
I haven't started anything. Pressure is nice, no bleeding.
Okay, fine. I will just check from my side.
All right, sure. I'll back up.
Okay, the circuit, yeah, looks fine. We check from circuit end to the patient end. Looks fine. ETT looks fine. Let's auscultate. Oh, one side of the air entry looks a bit under. Okay, can we just...
Okay, I am now going to pull out the ETT.
Pull out the 1 cm. Better now.
Okay, right now it's at 20
So one of the cause we
centimeter.
need to think about whether is this a pneumothorax. My ultrasound is here. Thank you. Okay, let's scan. Okay, lung sliding. Present. Lung sliding. Present. Unlikely to be a pneumothorax. Okay, very good.
May I continue?
Yes.
All right. So, starting operation, laparoscopic.
Let's play some game.
Okay.
Ding, 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 ding.
Mr. Don, can I know what sound is that?
I think there's a bleeder over the splenic vessels, I think.
Ayo. The blood pressure is dropping.
Alright.
Jennifer, can we please up the colloids and crystalloids and run bolus? We need more lines. Ultrasound.
I'll try my best to stop the bleeder.
Can we get the lines? Pass to me, the lines.
Okay.
Okay. Let's get a line. Okay. I will get the art line as well. Alright.
Will you want me to send the ABG?
Yes, after I get the
This
alight.
moment?
Okay? Yeah. Can we get a 10cc syringe? Okay. Syringe. Run for arterial blood gas. Okay? In the meantime, continue to resuscitate the patient. Okay?
Okay, Dr. Yo, how much is the EBL right now?
The EBL, what do you think?
More than 1 liter, maybe.
Hold on, let me have a look. Oh, yeah, that's quite a lot.
Okay.
It's already 3 liters.
Feel is not good. I'll convert to open right now.
Okay, very good.
Okay, converting open.
Very good. Okay, can we top up muscle relaxant?
1
okay.
ml pack.
And also morphine. Okay, please top up another 3 mg.
3 ml
right?
pack.
And
4 ml pack. 1 ml pack out.
Oh, wait.
2 ml pack out.
Okay. Can we
3
please
ml
get more
out.
blood? I need the blood to be in now.
Okay, I'm calling the blood
Okay.
for the to
4.
activate the
I also might need
transfusion
the massive
protocol.
transfusion protocol to be activated soon. Okay. During this period of time, can we please keep the temperature normal? Okay. Make sure there's no acidosis, no coagulopathy, and also look at the calcium. Have my ABG come back, please?
Okay, I got secure the bleeder.
Doctor, this is your ABG.
All right.
It shows metabolic acidosis, increase in lactate and sugars.
Yes, can we just start some insulin, about 3 units per
This is the
hour?
insulin.
Yeah, and also calcium. I'm going to give a calcium gluconate 1 gram of calcium gluconate.
This is the calcium.
Okay.
And this is the NOAD.
All
I'm
right.
dilating 2 mg in 50 cc, running
Okay,
at
giving
0.5
slow.
ml per kg
Okay.
now. I
How's the
will titrate
patient,
the BP.
Dr. Yo?
The patient is getting better. How is your bleeding?
It's bleeding secured. I'll finish in a few minutes.
Minutes?
Half an hour.
Half an hour,
One
yes.
hour.
All right, very well. All right, so
Closing.
Jennifer, I think the patient is getting better now. Still a little bit of tachycardic and also a little bit of metabolic acidosis. I think this patient needs to go to the ICU for
I will
post-op
call the
weaning.
ICU.
Yeah. Okay, can we please call up the ICU team? Okay. Hello, ICU.
Hello, ICU.
Yeah, ICU, I would like to pass over a case here. This is a case of a laparoscopic sleeve gastrect, and patient is morbidly obese, anticipated difficult airway, but we settled the airway for you. All right, and however, intraoperatively, the surgeons have perforated one of the big vessel, the artery. Yeah, don't ask me why. Don't ask me why. All right. Yeah, and the bleeding happens, but we resuscitated accordingly. Okay, and still slight metabolic acidosis, and I think this patient needs a post-op ICU for post-op weaning and respiratory. Watch out for respiratory failure.
All right, coming ASAP.
Thank you very much. All right,
Doctor, ICU team is here.
So fast.
Ventilator also available.
Oh, okay. Yeah. Okay, so can we please send the patient to the ICU?
Okay,
all right?
sure.
Yeah. But in the meantime, surgeon, are you done?
Yeah, I'm done.
Okay. Yeah. So in the meantime, we will push the patient to the ICU. Okay, and I will like to have a debriefing with all of you. Okay.
Sure.
Jennifer, how are you feeling now?
I'm feeling so upset.
So upset? Why?
Because I can't even get a line.
Don't worry. We will provide more training. Ultrasound is here.
Yeah,
All
I
right.
think I need to attend the course.
Yes. Okay. Mr. Don, are you okay?
Today was unfortunate, but
It's okay.
But I'll do better tomorrow.
We do better.
We do better.
All right?
All right.
Thank you. Yeah. Okay, done.
Thank you so much, Malaysia team. Please come forward. It's very relaxing, right? And everybody enjoy that. So now we have 5 minutes for the judge. Please, Dr. Rowan.
Fabulous work. Really felt like I was in the operating room. I think it was a very simple case, but there were very subtle suggestions that there was a lot of detail taken into consideration. I really liked the way you managed the airway. You thought through problems at the time. You rechecked tube. You listened to the chest. These are very nuanced observations, which I thought were done very well. Most importantly, I really was impressed with the anaesthetist. Just really great. A great culture in the operating room made everyone feel relaxed, and for me, the scene flowed very well because everyone felt psychologically very safe, and I think there's a lot to be learned from that, so Congratulations.
Thank you. Thank you. I just like to add on as well. I think this is how I usually practice my daily anesthesia, because I think in the scenario of crisis, the anesthetist is the one that has to stay calm and control the scene. And usually, yes, actually most of the time we are very worried, but we have to show that we are not at all. Yeah. And also we have to bear with our colleagues, all right? And of course, we have to understand how our team actually works. So that's why giving reassurance to the team, like for my nurses, all right, and the surgeons. I think all of us are still learning together. Yeah, and since we have a previous experience, we decided to improve it for the future surgeries as well. Yeah.
So the comment from India, Dr. Niran, please.
Excellent presentation, and we want such anesthetists in all the OR. Who is so interactive with the surgeon and the team. I had a question that you activated a massive transfusion protocol. So what in your institute is your massive transfusion protocol?
Yes, we have a protocol on board. Usually when the patient has a blood loss of exceeding the total blood volume, or more than half of the blood volume within 2 hours.
No, it's more than half the half blood volume, then we will activate it.
Yeah. So there is a protocol, but every centers are slightly different, but they are more or less with the same principle. Yeah. So using blood volumes losses as an indicator. Yeah. And I think for that case, 3 liter, I think that was already half of the patient's blood volume already.
Please.
Oh, okay. Congratulations, Malaysian team, for a very great performance.
Hi, Dr. Chi.
I was very impressed that this is the only team so far that actually have a timeout before the surgery. So they actually have a communications with the surgeon, then to brief everyone what type of surgery, what we're going to do, and things like that, and then the patients. So it's the first team with the timeout that I was very impressed. Just little things to please is when you have, I think we have a very, very competent anesthesiologist here, but then I think this small problem shared among all of us. Sometimes we tend to play a one-man show. I think it's important that we call for help at time that, for example, when things goes wrong, you need extra IV access with both arms actually strapped down, would be nice. And then it's a beast patient, the ventilation may need to be taken out. So it would be nice to call in an extra pair of hands for that, rather than you preoccupy with ultrasound-guided IV access. So that would be safer for the patient overall care.
I agree, Dr. Chi. Thank you very much. Thank you.
Thank you very much for the wonderful performance. Thank you very much.
Malaysians. Now we finish the 5 teams for the first round. And we haven't actually informed that we have a QR code for your favorite team. All of you, anyone can vote the favorite award team, beside the champion and also first runner-up.
And after scan this one, you can distribute this one as well, because to people outside of the room, because they can watch live as well from this scan as well.
Yes, but the award needs to be announced today afternoon, after all the 10 teams.
Okay, we will start to the next team.
For the second round, another 5 teams.
Welcome, Saudi Arabia.
Hello everyone, my name is Malak Abdulsari. I'm a 3rd-year anesthesia resident at King Abdullah Specialist Children's Hospital. Hello everyone, I'm Baptiste Hamad, a 4th-year anesthesia resident at King Abdullah Specialist Children's Hospital.
My name is Rayyan Muawad. I'm a consultant pediatric anesthesiologist. I'm the program director in the King Abdullah Specialist Children's Hospital and acting chairman of the pediatric anesthesia department.
My name is Mahab Abdullah. I'm 3rd-year resident at King Abdullah Specialist Children's Hospital.
We are preparing for reality.
Hello, good afternoon. I'm Ahmed Haroun, consultant pediatric anesthesiologist, and our team, Dr. Balqis, is a 4th-year resident, and she will play a role of associate consultant. Dr. Mohab is a 3rd-year resident, and he will play the role of a surgeon. And Dr. Malak will play the role of nurse. He's a 3rd-year resident also. Our scenario today, or the patient we will manage today, is an infant with a single ventricle physiology. It's becoming very common now to face single ventricle and various stages for surgery or imaging procedures or cardiac for non-cardiac procedures. So it's a 10-month-old who has a double outlet right ventricle, tophatrology of Fallot with severe pulmonary stenosis. He had a BT shunt after birth, modified BT shunt. And after 4 months, at the age of 4 months old, he had a bidirectional Glenn shunt. Now he was referred from cardiac ward for bilateral inguinal hernia repair. Patient is stable. We have assessed the patient. The echo shows patent shunt and good ventricular function. And the cardiac anesthesia and pediatric cardiology have no problems to go for surgery. We kept him NPO, prepared the room, kept it warm, started fluids from night to avoid dehydration. And now our team is going to induce him in OR. Let's see how they would manage.
Okay, good afternoon. Let's start team briefing, please. My name is Malak. I'm the nurse for this case. Can please everyone introduce themselves and their role, doctors?
Good afternoon. I'm Dr. Mahab, the surgeon.
Good afternoon. I'm Dr. Balqis, Associate Anesthesia.
Thank you, doctors. Okay, we have here a 10-month-old baby boy, 8 kilogram, medical record number 9891, no known allergies. Dr. Mohab, can you please confirm the procedure?
Okay, this patient will go for bilateral inguinal hernia repair.
Is it laparoscopic or an open approach?
Laparoscopic.
So, Dr. Mohab, I recommend to proceed with an open approach as the patient, his post-Glenn. So, the intra-abdominal insufflation might compromise the Glenn flow, leading to hemodynamic instability and also acid-base dearrangements.
I understand your concern, but let's do it as laparoscopic. Inshallah, it will be smooth. It's associated with less pain, faster recovery, and shorter hospital stay.
All right, just make sure that you start the insufflation slowly with initial internal abdominal pressure with 6 millimeter mercury with hard maximum 8 millimeter mercury.
Don't worry about it.
Thank you. Okay, let's proceed with induction.
Okay, Dr. Balqis, what's your plan?
So our plan it will be general anesthesia using modified rapid sequence induction using fentanyl 1 mics per kg, ketamine 1 milligram per kg, rocuronium 1 milligram per kg, and please prepare a cupped endotracheal tube size of 3.5.
Understood, doctor.
Starting pre-oxygenation.
8 microgram fentanyl given. 8 milligram ketamine given. And 8 milligram rocuronium N.
Thank you. May I have the laryngoscope?
Sure.
Tube size 3.5?
Yes.
Okay. Let's ventilate. Equal bilateral entry. Let's fix it at 10 centimeter.
Sure, doctor. Okay, fixation at 10 centimeter.
Okay, just make sure there is no compression over the jugular vein to avoid the SVC obstruction. Ventilator setting, FI to 60%, tidal volume of 50. And respiratory 36. We'll keep the beep less than 3. Dr. Mohab, we are ready to start?
Are we ready? Yes. cleaning and draping the patient. Okay, cleaning done. Yalla, nurse.
Okay, Dr. Balqis, permission to start, please.
Go ahead.
Yalla, help me. Starting. I'll insert first stroker now. Nurse, can you inflate to 6, please?
Sure, doctor. Pressure is 6 now.
Okay. Second stroker is in. Still low visibility. Can you increase it to 8, please?
Pressure is 8.
Oh, still low visibility. Can you put patient on Trendelenburg position, please?
Sure, doctor. Trendelenburg position.
Still low. I cannot see. Can you increase it to 10, please?
Okay. Pressure is 10.
Can you increase it to 12, please?
12, doctor. Okay. Pressure is a 12.
Something is wrong. Patient is desatting. Heart rate and peak air pressure are rising. And also the entire CO2 is increasing. Can someone call for help, please?
Sure, doctor.
I'll check the blood pressure.
Dr. Harun, can you please come and help us in room 1?
Okay, coming.
So, I'll put the 100% oxygen. With high flow and increasing the respiratory rate with minute ventilation and keeping the beep less than 3. Blood pressure is low. Nurse Malak, can you please give a bolus of a fluid 10 ml per kg?
Sure, doctor.
Is everything okay, doctor?
Actually, I think this is most likely gland flow impairment, but we need to exclude the other causes.
Dr. Balqis, 80 ml crystalloid given.
The circuit is patent. Tube is not king and remains at 10 centimeter. There is no compression over the jugular vein. Exposing the chest, there is no rush. Let's auscultate to see if there are any added sound. There is equal bilateral air entry. No wheezes or other added sound. Can I have the section?
Dr. Balqis, by the way, pressure is a 12.
No secretions. What?
Pressure is a 12.
Really? Dr. Mohab, deflate the abdomen immediately and
sure,
level
sure.
the bed, please.
Okay, abdomen will be deflated now.
Abdomen deflated and bed is leveled.
Let's obtain an ABG.
Sure, doctor.
Hi, Dr. Balqis. I'm Dr. Arun. Anything? Any problem?
Hi, Dr. Harun. So this is, just in brief, this is a 10-month baby boy. He's post-Glen, undergoing elective bilateral laparoscopic inguinal hernia repair. The induction went smooth. After the surgery started, the internal abdominal insufflation, the patient starting to desat, hemodynamic unstable. So we tried to exclude all the causes, and then the nurse Malak informed me that the patient, he's under pressure of 12, so we deflate the abdomen immediately, and also we level the bed.
Okay, and then any improvement?
Actually, patient starting to improve a little bit, but still the blood pressure is low.
Dr. Balqis, ABG result is here. pH is 7.1, CO2 69, O2 is 48, and electrolyte within normal range, lactate 1.6, and hematocrit 45.
Sure. As you can see, Dr. Harun, the blood result and the blood gas show during the crisis a severe hypercapnia resulting in respiratory acidosis with a significant hypoxemia despite 100% oxygen. Lactate remain within normal limit, indicating acute physiological deterioration rather than prolonged low cardiac output. So what do you suggest, Dr. Harun?
You give a bolus of fluid?
Yes, we give already 80 ml
Can
crystalloid.
we check X-ray and ultrasound?
Sure. Can we call for
examination?
the chest X-ray technician?
Sure, doctor.
Ultrasound, rapid
Yeah, we have
chest
ultrasound
examination?
here. We'll do BOCUS to see the heart and the IVC. And also we'll see the lungs as it is fast and cost effective. So IVC, it's compressible, so patient actually need the fluid. There is a good heart contractility. Both lungs, it's normal. There is no signs of pneumothorax. So these findings indicate a gland flow impairment rather than low cardiac output or myocardial or ischemic event.
Okay, you like to give another bolus of fluid?
Yes.
Okay, so I'm gonna give more fluid, 80 ml.
Blood pressure is still low. We need to give epinephrine 0.5 mics per kg, please, Dr.
Okay,
Malak.
sure, doctor. So epinephrine 4 mics is given.
Patient starts to improve.
Can we resume the surgery or late already?
Let's see the vitals.
Let's repeat on blood gas again.
Yeah, but first we need to see the vitals. Now the blood pressure is improving. He is returning to his baseline, so better to repeat the ABG before we are resuming.
Sure, let's do it fast.
Sure,
We
doctor.
don't have the whole day.
ABG sample taken.
So, Dr. Mohab, we need to resume the surgery with an open approach as the patient safety takes a precedence over the surgical technique.
Sure, don't worry.
Dr. Balqis, the ABG result is here. So pH is 7.3, CO2 38, O2 70, and lactate 1.4.
That's great, perfect. So these findings indicating a successful restoration of gland flow. So in conclusion, the blood gas confirms to us that the hypercapnia is the main driver of increased pulmonary vascular resistance, leading to compromised gland circulation.
Okay,
End
good
of the
job.
scenario.
Okay, so patient will go to HDU after the procedure. You will extubate, right?
Yes, we're gonna extubate the patient and sending him to HDU.
Okay.
Okay. Sure.
Okay. And then the patient was shifted to high dependence unit after extubation. He was in a stable condition.
Congratulations.
Thank you so much.
Thank you.
It's very serious situation for laparoscopic surgery in neonate.
Right.
Yes.
Yeah.
Right. It's very difficult case.
Yes,
Right.
very serious. Everybody like pay attention to the baby.
Do you have
What
this
happened
kind
to
of
the
case
baby? Yes.
in Australia, in Korea?
Yeah, maybe just want to make a comment.
Dr. Niran, please.
I very well managed such a complex, the case was, the surgery was maybe simple, but the patient had complex coexisting diseases. I have more than question also, comment also. Like single ventricle physiology, these patients are very much dependent on the venous return. So one comment is that as you first asked surgeon that whether he can do an open surgery, then the laparoscopy would be better. You could have done in the block along with minimal sedation. So you could avoid the endotracheal intubation and the positive pressure ventilation. Positive pressure ventilation increase the PVR. So it's a fine balance between the pulmonary vascular resistance and the systemic vascular resistance. So that is one thing which will hamper. So could have convinced the surgeon to do an open with a block and minimal sedation. That is one thing. And of course, you conducted the crisis and managed it very well. Congratulations for that.
Thank you.
Thank you.
Dr. Jay Kongkim, please.
Yes, very interesting case and very difficult. We all know patient with PT shunt is the most difficult ones to manage, very unstable. So my only question would be then, you did excellent intraoperative management, but the patient's age or month may indicate the patient should have already received Glenn shunt at least. So hernia is usually not a urgent or emergent surgery. So in that case, would you have suggested the surgeons to do Glenn first and then
actually
do
the patient
hernia?
is a post-Glenn shunt. He's a
Post-Glenn?
post-Glenn shunt,
Oh.
yes. Yeah. Yeah.
Oh, I missed it.
Okay,
Okay.
this is the most stable stage that you can do any surgery.
Okay.
Yeah, but
Yeah, great. I think very complex patient, and again, really impressed by the calmness in which you managed this infant. I thought that the communication was excellent, and I thought the correct clinical decisions were made in the best interest of the child. Nice to see such good communication between the entire team. So congratulations.
thank you. Thank you.
Thank you so much,
Thank you.
Saudi Arabia team.
Thank you.
We need some time for transition, right?
Yes,
For
because
transitions.
the next team
In
still
the
preparing.
meantime,
I like yes.
I like to introduce a lot of VIP joining as well. For example, we have the presidents, Chen Wang, Dr. Chen Wang, the president of Asian Society of Cardiac Anesthesia, is coming to join us as a VIP as well. Right. And Florence is the past president of the World Federation Society as well.
Welcome.
Thank you very much. And next, we will move to the next team. Hopefully, you can make it in time, right? In the meantime, during transition, I would like all of you to scan in front of you for the popular award, the third team that you like to, or maybe you can share this one to all around the world, because we can see online as well.
Can we vote more than one time or only
Only
or
one.
Only one?
One for one mobile
You
phone.
can wait until the 10 team finish.
Okay.
Otherwise, if you vote, you cannot vote no more.
Okay.
Yes,
Next
this-
team, we will go to China.
Please welcome China team again.
Hi, I'm Feng Hua. I come from Xuanwu Hospital, Capital Medical University.
Hi, I'm Jindy from Xuanwu Hospital, Capital Medical University.
Hello everyone, my name is Liu Qian. I'm from Xuanwu Hospital, Capital Medical University.
Hello, my name is An Yi. I'm from Xuanwu Hospital, Capital Medical University.
Hello everyone, my name is Zhang Shuning. I'm from Xuanwu Hospital, Capital Medical University.
Action concert,
Race Against Time. We are the A team.
Distinguished judges and fellow professionals, good afternoon. I am Jindy. I will be the anesthesia doctor today. And this is Dr. An Yi. He will play as the surgeon. And Dr. Zhang Shuning will play as a nurse. And Dr. Liu Qian will be controlling the program today. The case we present today is an elderly patient with well-controlled hypertension and no other severe comorbidities. Her pre-anesthesia evaluation was unremarkable, except the chest X-ray finding of pulmonary emphysema. And now we will proceed with the reenactment of the scenario.
Okay, let's gather around for the patient safety verification.
Okay, this patient is a 77-year-old female scheduled for olive.
The planned anesthesia is general anesthesia with intratracheal intubation. The equipment safety check have been completed. The monitoring has been initiated. Patient has a documented history of penicillin allergy.
Okay, the patient's consent forms all signed and IV access well established.
Okay, the induction begins now. Please take deep breaths, you're about to go to sleep. Start continuous infusion of propofol, remifentanil, and norepinephrine.
Okay, all started.
Okay. Give methylprednisolone 40 milligram IV injection.
Okay, methylprednisolone 14 milligram.
Sufentanil 10 microgram.
Sufentanil 10 microgram.
And etomidate 6 milligram.
Etomidate 6 milligram.
Please take deep breaths, you're doing well. Ma'am, please open your eyes, please. Give rocuronium 40 milligram.
Okay, rocuronium 40 milligram.
The blood pressure is dropping. Speed up the fluid.
Okay.
Give phenylephrine 100 milligram IV injection.
Phenylephrine 100 milligram.
No response. Repeat phenylephrine 100 milligram.
Okay, another phenylephrine 100 milligram.
Okay, still no response. Patient has extensive flushing all over the chest. Suspects anaphylactic shock. Call for help immediately.
Okay.
Prepare adrenaline 100 microgram per milliliter.
Okay.
And methylprednisolone 160 milligram. I'll intubate now. Give me a hand. Give adrenaline 100 microgram.
Okay, adrenaline 100 microgram.
Use pressure bag for
Okay.
fluid. Increase the dosage of norepinephrine, decrease the dosage of propofol and remifentanil.
Okay, all done.
Give adrenaline 200 microgram. Increase the norepinephrine further.
Okay, adrenaline 200 microgram.
Support team is here.
Okay, establish more IV lines.
Okay.
Okay, give adrenaline 500 microgram.
Okay, adrenaline 500 microgram.
Okay, use pressure bag for all fluid infusions. Start infusion of adrenaline.
Okay, infusion of adrenaline.
Give adrenaline 1 milligram IV injection.
Adrenaline 1 milligram. Oh, you want the telescope?
Yes. Repeat adrenaline 1 milligram IV injection.
Adrenaline 1 milligram. Please ask for a telescope. Surgeon, please help us.
Okay.
Start chest compression.
I'll do it for him.
Okay, I'll do it.
Okay, prepare the defibrillator.
Okay.
Give adrenaline 1 milligram IV injection.
Adrenaline.
Prepare the NAS cap.
Okay, I'll get an ice cap. Ice cap is here.
Very effective compression. Please continue. Okay, pause compression. There are signs of spontaneous circulation returning. Okay, patient's hemodynamics are temporarily staying now. Prepare the ultrasound machine for me.
Okay.
I'll perform a TTE to evaluate the volume status.
Ultrasound is here.
echocardiogram shows underfilled ventricles, suggests severe hypovolemia. Continued infusion of norepinephrine and adrenaline. Start infusion of terlipressin at 0.5 milligram per hour.
Okay, terlipressin started.
Give albumin 10 gram IV injection slowly. IV drip slowly.
Albumin 10 gram.
There are frequent premature ventricular contraction. Give lidocaine 60 milligram IV injection.
Okay, lidocaine 60 milligram.
Obtain a blood gas.
Okay, I'll do the test now.
For response, repeat lidocaine 60 milligram.
Okay, lidocaine 60 milligram.
Add magnesium 2.5 gram to the IV drip to stabilize myocardial cell membranes.
Okay, magnesium sulfate. Started.
How's the blood gas?
Okay, the test result is back, and the pH is 7.219, and calcium is 0.97, potassium is 2.8. Other abnormalities are here.
Okay, give sodium bicarbonate in 150 milliliter IV drip to correct the acid doses.
Okay, sodium bicarbonate, 150 milliliters.
Okay, add potassium 1.5 gram to the IV drip.
Potassium 1.5 gram to the IV drip.
Okay, give calcium chloride 0.6 gram IV injection slowly.
Okay, calcium chloride started.
The oxygen saturation is dropping. There are audible moist crackles all over both lungs. Prepare the ultrasound, do a lung ultrasound.
Okay.
You see those B-lines on the ultrasound? That suggests pulmonary edema. What is the current input and output?
Well, the current input is about 6,000 milliliters, and the output, the urine, is about 100 milliliters.
Okay, give furosemide 20 milligram IV spray.
Okay.
IV injection.
Furosemide.
How is the patient now? Should we consider calling off the surgery?
The patient just had a severe anaphylactic shock. While her hemodynamics are temporarily stable, she still needs further intensive monitoring. I recommend calling off the surgery.
Okay, thank you. I understood. Thank you for your prompt and successful resuscitation. I will talk with the family and calling off the surgery. Thank you.
The oxygen saturation is within the normal range. The crackles are clear. I'll repeat the lung ultrasound.
Okay. Here.
The B-line disappeared. It's normal now. Repeat an artery blood gas test.
Okay, I'll do the test now. And the results are normal now.
Okay, draw blood for the cardiac biomarkers test. I'll repeat NTD.
The test is also normal.
The echocardiography and the biomarkers shows no significant abnormalities. The patient's vital signs are stable now. Start weaning off the vasoactive agents. And this is a true case that happened in our department. After sustained and intensive resuscitation and management over 6 hours, the patient had ultimately regained normal vital signs, emerged from anesthesia, was extubated in the operating room, and discharged with no complications. We believe that the successful management of this case can be attributed to following factors, and the early recognition of anaphylactic reactions, the rapid resuscitation and to fluid resuscitation to ensure the perfusion of vital organs, the stepwise administration of adrenaline, balancing the fluid management against the risk of pulmonary edema and its management strategy. Last but not least, the rapid response and collaboration of multidisciplinary teams. Thank you all for your time. We really appreciate your expert critique and valuable perspective on this case. Thank you.
Thank you so much. Suanwu Hospital from China. Could you please come forward? So, severe anaphylactic shock and also cardiac arrest. So I think we have 5 minutes for the comment and also from the judge. Yes, please, Dr. Lauren.
Well managed. I really enjoyed the effective communication. I think repeating all the instructions was very effective. When a drug was asked for, it was repeated. I thought that was excellent.
Thank you.
What is your protocol for the checking of tryptase levels in your hospital? And what follow-up instructions did you provide to this patient? And what was the culprit agent if this was a real case?
For the safety verification, the surgeon and the nurse and the anesthesia doctor will gather around to check if the name, age, and the surgery method is correct. The surgeon's side is correct, and if all the preparation has been finished, and if all the the consent form has been signed, and then we will start the anesthesia induction.
That's great. My question was, do you send off any tryptase levels to confirm anaphylaxis in your hospital? And what is your protocol, so we can all learn from your protocols in your hospital to confirm anaphylaxis? And what is the follow-up for the patient to check for anaphylaxis and confirm what the culprit agent was in case they need another anesthetic so that drug could be avoided?
There's one hospital, the Beijing Union Hospital. They can do the allergy test for the anesthesia drugs, but our hospital cannot perform the test. So if patient had anaphylactic reaction in former surgery, we recommended to go to the Peking Union Hospital to check for the thing that causes allergy. And
test, right? Test.
Yeah, and when the result come back, they will recommend to avoid the usage of certain drugs. Thank you.
Yes, thank you so much. Any more comment from the judge? Because we still have some time left and we need to, the next team still preparing. Please.
Yeah, excellent case. And when I heard at the last of the case that it was a real case,
yes,
I was moved.
Thank you so much.
It seems that you gave bicarbonate maybe a little bit too early, but it depends on the clinical scenario and case. Do you have any specific indications for giving bicarbonate to your patients when you see your patients have acidosis and instability?
Maybe we read too fast. Her pH was 7.219. It was a severe acidosis, so we choose to give sodium bicarbonate. And we also believe if the patient was in severe acidosis, the vasoconstrictive agents may not work well, so we tend to use it more progressively. Thank you.
So for the special guest, if you have any comment, you can raise your hand. So thank you so much for China team, second team. Thank you, congratulations.
Thank you.
So now we 7 teams so far. If you like which team, you can scan the QR code for the favorite award team. But they also have another champion award and also first rounding up for the 2 position and also excellent, outstanding award as well. Because you can only vote 1 time. If you vote second time, it will be not working. And now we are in the 7 teams so far. So I think the next team almost ready. Next team, please welcome Philippine team.
I am Arian Ramirez, Thoracic and Cardiovascular Anesthesia Fellow.
I'm Carla Villasin, Thoracic and Cardiovascular Anesthesia Fellow.
I am John Padawan, Anesthesia Resident.
I am Lorena Osorio, Anesthesia Resident.
And I am Grace Catalan, Anesthesia Consultant.
We are the smooth operators. No rush, no rush.
Hello and good afternoon, everyone. We present the perioperative management of a patient with anterior mediastinal mass and mediastinal mass syndrome. Our patient is AA. He is an 18-year-old male presenting with progressive dyspnea, orthopnea, swelling of upper torso. Aside from bronchial asthma, his other medical history is unremarkable. On physical examination, we find wheezes and decreased air entry, tachycardia, and distended neck veins. Other systemic PE is unremarkable, including the airway. Chest X-ray showed a widened mediastinum and tracheal compression. Tumor markers beta-HCG and AFP are elevated. 2D echo showed good biventricular function. A chest CT was done, showing an 8 by 8 by 6 centimeter tumor with appearance suggestive of a mediastinal germ cell tumor. This causes 75% tracheal compression. Likewise, there was compression of the superior vena cava and the left pulmonary artery. The surgical assessment at the time is a huge anterior mediastinal mass with mediastinal mass syndrome. ASA classification 4, high risk for difficult airway and hemodynamic collapse under anesthesia. So given the degree of the airway and vascular compression, a multidisciplinary conference was convened involving the medical and surgical teams as well as the patient and the family. The decision was made not to proceed with surgery first, but rather to initiate neoadjuvant chemotherapy prior to the tissue diagnosis. After 3 cycles of chemotherapy, there was improvement to 50% tracheal compression. However, the pulmonary artery is still compressed, and there was only slight relief of symptoms. The patient is still, therefore, high risk for airway and hemodynamic compromise. We proceed with our crisis resource management.
Okay, everyone, let's pause for a timeout. Hello, AA. We're just gonna discuss your case a bit, all right? So this is an 18-year-old male, 69 kilograms. Our case is an EBUS-guided biopsy for anterior mediastinal mass. Okay, I'm Dr. Arian. I'm your anesthetist for this case.
Hello, I'm Dr. John. I'll be your cardiothoracic surgeon.
And I'm Carla, your scrub nurse.
All right, do you guys have any questions or concerns?
None so far.
Okay, so the surgeon and I devised 3 plans for this case. For plan A, we would keep spontaneous breathing, no paralytics. If there is airway collapse, we will do rigid bronchoscopy plus tracheal stenting. If there is hemodynamic collapse, we will proceed to plan C. Okay, we will do mechanical circulatory support. Are we aligned with our plans?
Yes. If ever we proceed with Plan C, we will need femoral access and ideally put the patient on ECMO. However, due to limited resources, we will proceed with cardiopulmonary bypass instead and possibly resect the tumor. Is that okay?
Okay, surgeon. This is noted.
Okay.
Hello, AA. We're gonna keep you breathing as long as we can, but if you have any trouble breathing, just let me know right away, okay? Let's start with the induction. Please give the medication slow and steady.
The hemodynamic monitors are working as planned. The suction ready are prepared, and our rigid bronchoscope and our ultrasound are there. And for emergency cannulation, we have our femoral cannulation tray and ultrasound also ready. We have prepared 3 units of PAC-RBC for this patient, so I guess we're ready.
Okay, that's great.
Okay.
Now, please give slowly atropine.
Sure. Atropine given.
Okay. Please start remifentanil.
Starting remifentanil infusion.
Then please give slowly ketamine, then propofol.
Okay. Giving ketamine. Slowly giving propofol. Saturations, 98%. BP, 120/80. No changes in hemodynamic parameters.
Okay, good chest rise, good airway pressures. I will now insert the LMA in. LMA in.
Okay, capnography present. Bilateral chest rise. I'll auscultate. Good air entry, but I think there's inspiratory wheezing, doctor.
Let me cross-check. Agreed, there's wheezing.
But we have stable vital signs. So far, so good.
Okay, thank you very much for the smooth induction. I will now proceed with the EBUS guided biopsy. Opening the part now.
Wait.
Something's alarming.
Our machines are alarming. It says high airway pressure. What's happening?
Okay, what's happening? Anesthesia, I'll stop the biopsy now.
Agree, echo is dampening. This is dynamic airway collapse.
These oxygen saturations are dropping. Now
the
70%.
Nurse, assist her.
Tell me what to do.
I'll try to railroad an EPT past the obstruction. I'm meeting resistance. The lumen is still collapsing.
His lips are turning cyanotic.
This looks like extrinsic compression.
The patient
The
is
armored tube
crashing.
won't be able to bypass. Should we proceed with plan B, anesthesia?
Agree.
Okay, let's do rigid bronchoscopy and prepare now.
Please give rocuronium now.
Are you sure? You said no muscle relaxants before.
Yes, this will improve airway dynamics.
Can you move faster, please? I'm about to insert the scope.
Aspirating rocuronium. Giving rocuronium
Okay,
now.
inserting the scope now. Anesthesia, can you ventilate via side port, please?
Oxygen via rigid.
Okay, the airway is still narrow. Should we stent now?
Yes.
Is that okay?
Proceed.
Okay, please, nurse, please give me the stent. Okay, stenting now. C-arm ready?
C-arm ready.
Okay, stent deployed. How's the ventilation, anesthesia?
Ventilation is intact. Good job.
Oxygen saturations improved.
Okay.
But, doctors, the BP is dropping. He's
Oh no, what's happening?
hypotensive.
Secure the airway first with an ET tube.
He's turning bradycardic at 60.
Nurse?
Cardiac index and systemic vascular resistance
Stop panicking,
also low.
Please give phenylephrine bolus now. Start norepinephrine, have vasopressin and dobutamine on standby.
That's a lot.
Anesthesia, what's happening? Nothing's going right now.
This is
Giving
cardiovascular
phenylephrine
mediastinal
bolus.
mass syndrome, obstructive shock.
I agree. Should we proceed with plan C and go on mechanical circulatory
Starting more
support?
epinephrine
Yes,
now.
let's go. Can you access the femoral now?
What? Do I have to do everything? Call for help now. Have someone else prep the groin.
He is still hypotensive, doctor.
Okay, I'm here.
The patient is crashing.
Okay, I'm scrubbing in now.
What do I do? Tell me what to do.
Prep the groin and insert the
Okay.
guide wire.
Preparing the groin side. Getting the ultrasound. Okay. Femoral
He's still
access is ready.
hypotensive, doctor.
We can
The
cannulate
patient
surgeon.
is crashing. I think you need to move a bit faster, doctor.
What do you think I'm doing? I'm doing my best. Why don't you just do your job?
Everyone calm down. We are prepared for this. We have the plans, okay? Let's go on bypass now.
Okay, cannulation is complete.
Okay. So with cardiopulmonary bypass established, the team was able to restore perfusion while bypassing the physiologic consequences of mediastinal compression. Definitive tumor resection was completed without further instability.
Okay, ventilation is intact. Good hemodynamics. Let's now transfer the patient to the ICU.
I'll endorse the patient to the ICU and will narrate everything that happened intraoperatively.
Okay, thank you, Anesthesia, for the help. That was a good save. Let's now transfer the patient to the IC.
Thank you.
Thank you.
Okay, everyone, that was indeed a challenging case. Let's pause and debrief for a while so that we may reflect on our case and then we may apply our learnings for our future cases. But first of all, I want to ask, how are you guys feeling right now?
Initially, I was angry and frustrated because nothing was going right. However, we were able to escalate our plans and save the patient from crisis.
I admit I was confident at first because we've laid out our plans, but I panicked and lost my thoughts, and I realized panic does not solve anything.
At first, I was very confused, but I'm glad I was instructed on what to do.
I also want to ask, what do you think went well and what do you think could have been improved with our management?
Okay, so what went well for me was that we had a very explicit plan A, plan B, and plan C.
We also still had effective communication since we were able to delegate our tasks, even if the emotions were all high.
We were also able to escalate our plans quickly because we were able to communicate effectively.
Okay. It's also good that we were able to de-escalate stress amongst our group, right?
Yes.
Okay. What do you think could have been improved more with our management?
Maybe we could have prepared the femoral access earlier.
Or we could have strict role assignments who mans the airway, the medications, and the instruments.
Yes. For future complex cases, maybe our institution can formalize a checklist for this case.
Agree with all your points. So overall, that was a high-risk anterior mediastinal mass case with hemodynamic and airway collapse. Hopefully, we can apply our learnings for our future cases, right? But that was a good save, team. That just proved our group dynamics as a healthcare team. So good job, and we were able to keep the patient safe. Thank you, guys.
Thank you. We move on to our discussion. So what we just witnessed was debriefing. So it's a very important aspect of crisis resource management since it highlights the reflective thinking and feedback of the members of the team. So essentially, crisis resource management includes stress management, situational awareness, as well as team building. So we are translating the knowledge of the anesthesiologist and teamwork to manage the critical incident in a perioperative setting. So important, we highlight here, failing to plan is planning to fail. So this highlights the importance of a multidisciplinary decision for our high-risk patient. So moving on to the case, so this flowchart highlights the importance of properly diagnosing the tumor type to guide our management. In the index case, a solid lesion on the CT scan, elevated beta-HCG and AFP, these point to a malignant germ cell tumor, for which chemotherapy and radiotherapy are the preferred management options before surgical resection. So after chemotherapy, there was minimal tumor regression, putting the risk classification of the tumor as unsafe. This necessitated low-dose titrated induction with spontaneous ventilation. To counter the airway collapse, our team did rigid bronchoscopy and tracheal stenting. Then to counter the cardiovascular collapse, we did vasopressor therapy and positioning, and when that was not enough, we followed with emergent cardiopulmonary bypass. So traditionally, in the management of patients with anterior mediastinal masses, we were taught that awake spontaneous ventilation was the way to go. However, there is a recent challenge to this assumption. On expiration, patients compensate from the reduced airway caliber from the positive pressure with prolonged exhalation and body positioning. However, we should note that this compensation is variable and not always protective. Therefore, spontaneous breathing does not uniformly prevent airway obstruction and may actually even worsen dynamic airway collapse. So, what if we consider positive pressure ventilation and neuromuscular blockade? So it's traditionally perceived that reduction in skeletal and smooth muscle tone with PPV worsens your central airway obstruction. However, it's been found that during inspiration and under anesthesia, both peak inspiratory flow and airway caliber are increased. During expiration, what we can do is increase the expiratory time to prevent air trapping. Actually, the more significant takeaway here is to recognize the causes of hemodynamic collapse in anterior mediastinal mass cases. Again, progressive air trapping. Without the appropriate ventilatory modifications we mentioned, there is an increase in intrathoracic pressure and decrease in venous return and cardiac output. Next, hyperventilation and the resulting alkalosis causes intracellular shift of calcium and potassium, impairment of cardiac function, and hypotension. Finally, there is, of course, the mechanical compression of the tumor to the heart and major vessels, which lead to collapse. ECMO is the ideal technique, again not available in our case, so we used cardiopulmonary bypass. So in summary, airway management for AMMs is dynamic. So we used high-flow nasal cannula, we prepared supraglottic airway, rigid bronchoscope. We can attempt intubation as long as we know the location and degree of obstruction and railroad the tube past that. We can use flexible bronchoscopy as well. Induction can be done with inhalational as well as total intravenous anesthesia. Positive pressure ventilation and neuromuscular blockade, again, superior to spontaneous ventilation. Finally, mechanical ventilation settings. Tidal volume via ideal body weight. IE ratio, we can increase from 1:2 all the way to 1:5. Lower respiratory rate, and keep our PEEP at 6 to 8 centimeters water. Thank you.
Congratulations.
Thank you so much.
Congratulations, Philippine General Hospital.
Well prepared and a lot of debrief, and that's right away after a situation happening that what's wrong with our action and reflect right away, so the audience can see
What a
all
wonderful performance,
yes,
right?
performance from the beginning until reviewing.
When we see the name of the Grace Catalan in the list, oh wow, right.
Yes.
So we would like to have the comment from the VIP guests as well. Cheng Wang, Professor Cheng Wang, please. Microphone.
Yeah, it's really a very challengeable cases. And we are happy to see the battle between the anesthesiology and the surgery. It's really a real scenes often occurs in operation theaters, the battle between the anesthesiology and the surgery. And what I want to know is how to assessment of this high-risk airway problem. And also for the bypass, if we can do some preparation for the femoral artery and vein cannulation before we start the intubation, I think it will be much more safe for this kind of patient. And what's your opinion about this?
Yes, you can see.
I agree with you. Actually, we included that as one of the points that we could have improved on.
They have microphone.
Okay.
Okay, I agree with you. Actually, that was one of the points that we wanted to improve on. We discussed that in the last part. We could have prepared the femoral site ahead in the start of OR, so we didn't, that's minus the cognitive workload later on, right? But that is something that could have been improved on that case.
Yeah, especially for this kind of very difficult airway situation. And if we use we are planning to use the bypass, maybe sometimes if we can use ECMO or something like. And also, we need to check the internal jugular vein if there's some very severe compress by the medius, the mass compress. And also, we need to check if we have the cerebral saturation for this kind of patient will be much more useful for this kind of difficult situation, something like. Okay.
Thank you very much
Okay.
for Cheng Wang. Thank you
very,
so
very
much.
nice cases.
Thank you so
Okay.
much.
This for the wonderful performance.
Yes.
Thank you. So we will move to the next team from, thank you for Philippine General Hospital.
Thank you. Next team already very, very ready. They all prepare for Russian team.
Hello everybody, I am Alexey Pyurega. I am Deputy Director of Anesthesiology and Intensive Care, Moscow Regional Institute. for obstetric gynecology named after academician Владислав Иванович Краснопольский.
Ladies and gentlemen, good day. I am Alessia Panamariva, doctor, anesthesiologist, and intensivist. And I'm working at the Institute of Obstetrics and Gynecology, named after Krasnopolsky.
Hello, my name is Maria Vislepina, and I am head of neonatology intensive care unit.
Hello, my name is Gleb Kuregov. I am a student paramedic.
Hello, my name is Maylead Konstantin. I am obstetrician and junior research fellow.
One team, one moment, one decision.
Dear colleagues, today we present a rare and catastrophic obstetric emergency amniotic fluid embolism with an exceptionally favorable outcome. This case highlights how rapid recognition, decisive action, and multidisciplinary response can alter prognosis in a condition traditionally associated with high mortality. Our team, AFE1. One team, one moment, one decision. Our patient, a female of 34 years old, her height is 155 centimeters, weight is 94 kilograms, BMI is around 39. She was hospitalized by AD with lower abdominal joint pain. Her primary diagnosis, pregnancy 35 weeks and 5 days, syphilic presentation. Primary diagnosis complications, uterine scar, status post previous C-section, threatened pattern labor, polyhydramnios, gestational diabetes mellitus, fetal congestional anomaly, obstructive intentional lesion. Associated conditions, obesity class 2, mild iron deficiency anemia. On the second trimester, fetal duodenal astrasia and polyhydramnios. On the third, severe polyhydramnios and confirmed fetal duodenal astrasia. So on the first day, the patient was admitted to labor and delivery unit. The observation was 11 hours. We planned the trial of labor after cesarean, and our patient refused this plan, so we arranged emergency C-section. Our planned procedure was emergency repeat cesarean section. Indication, pattern labor in a patient with a uterine scar after cesarean who refused our plan. Preparative assessment, physical exam on admission, stable hemodynamic parameters, no acute distress. Preparative visit, patient was conscious, alert, vital signs were within normal limits. Fetal heart rate was normal. Full live term male infant delivered, 2,450 grams, 50 centimeters, Apgar 7-8.
Baby is live, Apgar 7 and 8.
Patient is stable.
3 minutes after delivery, patient had motor agitation and anxiety, unresponsiveness to verbal contact, acral cyanosis.
Patient is unresponsive, acral cyanosis. Saturation is dropping. I think it's pulmonary embolism. Maria, could you bring focus, please?
What's happening? I think it's local anesthesia, systemic toxicity.
Oh no! Look at that. No thorax, no pulmonary hypertension. It's amniotic fluid embolism. You can see risk factors. Alessia, methylprednisolone, 400 milligrams intravenously.
400 milligrams intravenously. Emergency intubation. Ketamine, 100 milligrams intravenously. Rocuronium, 50 milligrams intravenously.
Ketamine, 100 milligram intravenously. Rocuronium, 50 milligram intravenously. Ready.
Emergency situation. Oxygenation with 100% oxygen.
First cardiac arrest. Assistal CPR.
Okay, CPR.
Epinephrine 1 milligram intravenously.
Epinephrine 1 milligram intravenously performed.
The amniotic fluid embolism is a rare catastrophic syndrome characterized by the sudden onset of acute hypotension or cardiac arrest, severe hypoxemia, coagulopathy leading to massive hemorrhage. Risk factors: polyhydramnios, advanced material
1 milligram
age,
intravenously.
gravida more than 5,
Epinephrine 1 milligram
cesarean
intravenously.
or instrumental delivery, placenta previa or abrasion, preeclampsia. Pathogenesis,
norepinephrine,
entry of amniotic fluid
0.2
components
microgram
into
per
material
kilogram per
circulation,
minute,
triggering an
intravenously.
anaphylactic
Norepinephrine
reaction.
0.2
Clinical
microgram
diagnosis
per
of
kilogram
exclusion.
per minute
No definitive lab test
intravenously.
exists. Novel biomarkers are under investigation. Clinical picture: sudden, rapid deterioration during pregnancy, delivery, or within 12 hours postpartum. Clinical diagnostic triad: acute hypotension, acute
Ventricular
hypoxemia,
fibrillation.
coagulopathy.
Clear.
Core management strategy: immediate resuscitation, hemodynamic support,
Defibrillation.
coagulopathy correction, immunodilation, advanced support. Crucial element: multidisciplinary team approach is vital for survival.
Sinus rhythm.
Second cardiac arrest: assistal CPR.
Methylprednisolone 400 milligrams intravenously and epinephrine 1 milligram intravenously.
Methylprednisolone 400 milligram intravenously performed. Epinephrine 1 milligram intravenously performed. Sinus rhythm.
Third cardiac arrest: assistal CPR.
Epinephrine 1 milligram intravenously.
Epinephrine 1 milligram intravenously. Ready.
Sinus rhythm.
Following stabilization, the surgical hemostasis was attempted. Ligation of uterine vessels, bi-Lynch compression sutures.
Tranexamic acid 1 gram intravenously.
Tranexamic acid 1.5 gram intravenously.
Fourth cardiac arrest: assistal CPR.
Epinephrine 1 milligram intravenously. Amiodarone 300 milligrams intravenously.
Epinephrine 1 milligram intravenously. Ready. Amiodarone 300 milligram intravenously. Ready.
Sinus rhythm.
Oh, free blood in abdominal flanks. Source: left hepatic lobe rupture and hematoma. Intervention: hematoma evacuation and left hepatic lobe suturing. Oh, uterine stays atonic. Need hysterectomy.
Activating massive transfusion protocol. Fresh frozen plasma 2 units. Red blood cells 3 units. Cryoprecipitate 10 units. Protonplex complex.
Cryoprecipitate 10 units. Protoplex complex continued. Fresh frozen plasma 2 units. Red blood cells 2 units. More and more.
Extent of surgery: emergency repeat C-section, ligation of uterine vessels, bi-Lynch compression sutures, suturing of a left hepatic lobe rupture with hematoma evacuation, hysterectomy with bilateral symplectomy, placement of 3 intra-abdominal drains, intraoperative resuscitation, CPR, methylprednisolone 800 milligrams, intubation and mechanical ventilation, defibrillation. Blood lost 4,500 milligrams. Urine output 300 milligrams. The patient is admitted to ICU, where intensive therapy continues. Severity of condition: multiple organ failure, preabdominal, respiratory, hepatic and renal failure, severe post-hemorrhagical anemia. ICU findings: neurology, acute hypoxia, ischemic encephalopathy, coma, cerebral edema. Ophthalmology, hypertensive type retinal angiopathy. No signs of pulmonary hypertension. Chest X-ray, diffuse areas of decreased pulmonary aeration. Sinus rhythm. No deep vein thrombosis. Cardiac biomarkers were within normal limits. At 12 p.m., clinical deterioration. Increased hemorrhagic output from abdominal drains. Tachycardia. We planned emergency relapartomy.
Massive transfusion protocol activating. Red blood cells 3 units, fresh frozen plasma 2 units, cryoprecipitate 10 units, and protoplex complex.
Pressure is falling. Protoplex complex continued. Cryoprecipitate more and more. Fresh frozen plasma and red blood cells.
Findings: rupture subcapsular liver hematomas with intraoperational hemorrhage. Extent of surgery: exploration, evacuation, and decompression of subcapsular liver hematomas. Surgical control of intra-abdominal bleeding. Total blood lost: 6,500 milliliters. Patient is transferred to ICU, where intensive therapy is continued. Key organ dysfunction: liver injury, severe cataclysm, hemolysis, acute kidney injury. Initiated extracorporeal therapy, therapeutic plasma exchange, hemodefiltration, 3 sessions. The duration was 160 hours. And the results: on day 5, she was extubated. On day 10, transferred with clinical improvement to a tertiary parenteral center for continued relevant replacement therapy. Day 14, transferred to ward. And on day 18, she was discharged in satisfactory condition with no neurological deficit. Alone, we can do so little. Together, we can do so much. Our team, FE1.
One team, one moment, one decision.
One team, one moment, one decision. One team, one moment, one decision.
Congratulations. Congratulations, Moscow. Wow. What's a great teamwork.
One team, one moment, and one decision, right? Excellent.
Right. Florian, do you want to give some comments? And we need some comment from the VIPs around because a lot of VIP coming as well. Please, Florian, please.
Yes.
Thank you very much. Congratulations, team. One moment, one decision. I'm happy you presented to us an obstetrical case and a complicated one. Definitely your decision points on how you arrive at the diagnosis was supported with all the monitoring and with the questions that you asked yourselves on what could be the possibility. Good job on your communication as a group.
Thank you.
Thank you.
Thank you very much. Before that, before we have another comments, I would like to welcome the President of Indonesia, in Indonesia as well. And Ajahn Warasuang would like to comment, all right?
Yes.
Professor Warasuang, please.
Thank you. I would like some question about the, I suppose that I would like to know about the In this situation, is an open abdominal wall cardiac arrest. It's better if the user start internal cardiac compression. It may be better than the external chest. What is your opinion? Yeah, because as I know that in the situation of abdominal wall opening, the effective of a chest compression may be not optimal. Yeah, thank you. Maybe, in my opinion, internal cardiac compression may be better, good cardiac output, better than chest compression.
More effective.
More
right?
effective.
I see.
But depend on the surgeon, you know.
Is it the capability of the surgeon to do that as well? Because we are anesthetists, we have to pursue the surgeon to do, right?
Yes, because in my country, you need to be CVT surgeon to do median sternotomy. Gynecologists cannot do it, so I'm not quite sure about Russian.
Right. Dr. Niran, please.
Excellent case presentation here. The good communication and prompt intervention, and a long day, of course. It's a long day you had. I have just one question. The rationale for giving FFP in combination with the prothrombin complex concentration for the massive transfusion protocol.
Зачем фактор вводили? When we need to increase the amount of plasma complex, we need to use prothroplex complex. It's the combination of factors.
Yes, I agree. Thank you. Thank you. Thank you very much.
Нанесу.
Thank you very much for Moscow. Thank you so much. Yes, thank you very
Do
much.
we need to move the podium back, or it's okay over here? Yeah.
Next team.
Now the last team of the day.
Is it the last team?
It's the last team now. It's the 10th
Wow.
team now. I think you guys must be very tired for the rest of the day. It's like almost 4 hours so far, or maybe more than 4 hours now. And the judge cannot go anywhere. I'm so sad. I'm so sorry for that. He's still moving around.
But because it's very exciting. This is
Yeah.
first time ever we do the whole Asia together.
Yeah, but
First time ever to do
No,
like
already
this.
getting tired for the rest.
Sembahang
The
Chapitan
10 teams so far. But I think the Indonesian team still have a lot of strength to
The
perform,
next-
right? Yes, they are still smiling.
The next team will be from
Indon-
Sipto Hospital.
Indonesia, yes.
Right. It looks like in Sililat Hospital in Thailand. Sipto is a very big hospital in Indonesia as well. So welcome Sipto University National Center Public Hospital from Indonesia.
Hello everyone, my name is Vina and I will introduce you to our team. Hello, my name is Hani. I'm Diana.
I'm Jonathan.
And we are from Trauma Guards. Initiate, coordinate, resuscitate.
Hi, good evening, honorable judges and all audiences. We are presenting a case of a 30-year-old male weighing 43 kilograms brought to our emergency department with acute respiratory distress and profuse bleeding from a neck wound. 30 minutes prior to arrival, patient was found on the bathroom floor, bleeding with a knife nearby. Initial wound coverage was done at the community clinic before transfer. Upon arrival, the patient was gargling, tachypneic, hypoxic, and actively bleeding from an open anterior neck wound with exposed trachea. A trauma code was activated. Trauma code activated. Trauma code activated.
Hello, nurse. What do we have now?
Well, Doc, we have patient on stretcher, currently on oxygen via 15 liters non-rebreather. Vitals BP 78/45, heart rate 130, respiratory rate 33, with saturations 87% and dropping. There's an anterior neck wound. It's currently covered with gauze, but the gauze is soaked. Patient has a peripheral IV, 18 gauge on the right hand, currently bolusing 1 liter of crystalloids.
Anesthesia?
Okay, I'll take an airway. Suction, please.
Suction ready.
Maintaining cervical stabilization.
Maintaining cervical stabilization. Lots of blood and clots, Doc.
Okay, ventilation temp.
Wait, air bubbles coming from the neck wound. The oxygen not improving, guys.
Okay, this will be the difficult ventilation scenario. Prepare for difficult airway.
Okay. Preparing for difficult airway.
Pressure apply.
Okay, keep the pressure applied to the neck wound, please, surgeon.
Gauze, please. Gauze, please.
Gauze, Doc.
Okay. Pressure applied, Doc. The oxygen saturation is now improving, but only 92%.
Okay, it's okay for now. Wait, tight back. Airway pressure is so high. Okay, I will proceeding with intubation with video laryngoscope using Salah technique. Suction, please. Suction ready.
Okay, suction ready.
Please give the patient 50 milligram of ketamine and 100 microgram of fentanyl.
All right, inserting 50 milligrams of ketamine and 100 micrograms of fentanyl.
Laryngoscope in. I see the cords. Tube in.
Wait. What is it?
Oh my God, the ETT has gone through the neck wound.
This is a tracheal rupture, everyone. You may be hurry because if we not, the oxygen will be dropping.
Okay. Oral intubation won't be successful. I will abandoning for the next oral attempt. Okay, I'll intubation from the neck wound. Tube in.
Wow.
Oh my God. Okay. Connecting to manual bagging.
Whew.
Confirm tube position.
Right. Both sides are present equally. Nurse, let me help you to take over the manual ventilation so you can secure the ETT.
Okay, thank you.
I will inflate cuff.
Securing the ETT at 14 centimeters at the neck wound.
Okay, ventilator is set. Connecting to the ventilator. Start sedation with midazolam and morphine 1 milligram per hour each.
Okay, starting sedation with midazolam and morphine 1 milligram per hour each.
All right. No problem. I need to check the patient's back so to make sure there's no other injury. Would you mind to leading the rock roll anesthesia?
Okay, on my count, roll to the left. 1, 2, 3.
Rolling to the left.
Okay, looks clear. There's no under injury part in here.
Okay, rolling back. 1, 2, 3.
All right, rolling back.
Okay. From my initial exam, there is no major vascular injury here. I need an urgent explorative cervicotomy and trachea repair surgery. Please call the OR to prepare surgery.
All right, Doc. I'll call the OR. I'll also get in another IV so we can bolus 500 milliliters of colloid. I'll make sure the OR is ready. Ordering some blood products too.
We are definitely need to secure oral airway surgery. But I can perform the surgery if there is endotracheal drop in the trachea. Anesthesia, do you have any plan to secure the surgery?
Okay, let me think. Okay, I have an idea. We will treat oral drop over bougie. You will treat the bougie distally and I'll catch it from above, okay?
Sounds good. I'll control the distal end. And also, the EVAS is clear. I'll go to the OR. Please call the OR.
All right, I'll get the OR ready. PRC transfusion 1 bag is running. I'll make sure they know we're on the way.
Okay, we will bring the patient to the OR with ventilator transport and monitor transport. I will escort the patient.
Patient was assessed with ASA4E. Patient was with anterior tracheal rupture with failed oral intubation and thus necessitating a front of neck access through the previous wound. Initial blood loss has caused the patient a grade 3 hemorrhagic shock, which is on resuscitation. From the EFAS, there is no other injuries From the laboratory findings, patient is still within normal limits. Cervical X-ray showed an extensive subcutaneous emphysema and an air lucency in the retropharyngeal space. From the chest X-ray, we get that the endotracheal tube tip was positioned 4 centimeters above the carina. Patient was then transferred with inline stabilization and escorted to the OR by the anesthesiologist. In the operating room, hi nurse, coming in hot from the ER. There is one patient, male 30 years old, with tracheal rupture, will undergo cervicotomy exploratory and tracheal repair. Patient currently is intubated through the tracheal wound with a size 8 ETT, cuffed fixation at 14 centimeters. Patient with hemorrhagic shock currently is ongoing his first bag of PRC. We've already given him 2 bags of crystalloid and 1 bag of colloid downstairs. Good luck, nurse.
All right, thank you. Hell of a day, huh? Okay, so OR is ready. Let's just commence timeout. Patient name and diagnosis.
Mr. YP, 30 years old, is going to explorative cervicotomy and trachea repair surgery. Consent confirmed.
All right, thank you. Surgeon name and surgical intraoperative concern.
Jonathan, and we will anticipate it for possible contamination and blood loss.
All right, thank you. Anesthesiologist name and anesthesia concern.
Anesthesiologist's name is Honey, airway and hemodynamic concern. Patient with ASA4E with tracheal rupture and hemorrhagic shock.
All right, thank you. Well, we have the airway devices, vascular clamps, and sutures ready. Antibiotic prophylaxis has been given. Timeout complete.
Right. Before we start the surgery, let's pray it will begin. Prayer begin. All right. Anastasia, are you ready to switch?
Okay, I'm ready.
Boogie, please.
Bougie, doc.
All right, clamp, please.
Clamp, doc.
I'm passing the bougie into the defect of the proximal trachea.
Okay. I have the bougie orally secure.
All right. Right now, I'm passing the bougie into the distal defect of the trachea.
Okay, you're done?
Yes, I'm done. Yes, got it.
Okay, I will treat the ATT of a bougie.
Wait, hold on.
Okay.
I already see the oral tube in the proxima of the trachea.
Okay.
I'm passing it to the distal of the trachea. Please remove the previous ETT on the trachea.
All right, deflating the old ETT, extubating the ETT from the neck.
All right, another clamp, please.
Clamp.
Yeah, here we go. Got it.
Okay.
Please secure it.
Removing the bougie,
inflating cuff,
and fixating.
How about the ventilation right now, Anastasia?
For now, ventilation is good.
Wow, you have a great idea. Okay.
Okay, you may continue.
Okay, I'm going to start surgery. Clamp, please.
Clamp.
And also scalpel.
Scalpel.
Man, oh my God, I think I hit some anomalous vein in here. Suction, please. Counter.
Suction. Counter.
Oh my God.
Give the blood bolus. Prepare for the blood transfusion, please.
Okay, preparing blood
Gauze, please.
transfusion.
Gauze, please.
Gauze.
I'm trying to control it. What is this? Okay. Right, it's controlled right now.
Okay, thank you. You may continue.
And 1 hour later.
I think I'm almost done.
Wait a minute. ETCO2?
Doctor, I think ETCO2 is dropping, doc.
Oh my God, ETCO2 is dropping. Blood pressure is falling. Saturation now only 90%. Please increase the fraction to the 100%.
Okay, fraction increase to 100%.
How about the surgical field, doc?
There is no bleeding in here right now, doc.
Okay.
Please.
I will running the dope check. Tube secure. Please the suction.
Suction.
Suture, please.
Suture.
No obstruction. Stethoscope, please.
Stethoscope.
I need more scissor. please.
Okay.
Lungs clear, equipment still functioning. Okay, I think the most consistent cause for this patient is air pulmonary embolism. Doctor, surgeon, please stop what you are doing now.
But I only need few more minutes.
No, you have to stop. You can continue after we finish resuscitate. Please.
Fine. What do you want me to do?
Okay, please flooding the surgical fluid with fluid and cover it.
Okay, flooding the surgical field with saline.
Go, please.
Goes, doc.
Cover it.
Make the patient to the treadle position.
Okay, positioning patient in treadle position.
Give the fluid boluses.
Fluid boluses starting.
And start the dobutamine from 5 microgram per kilogram per minute via central line.
Okay, dobutamine 5 micrograms per kilogram per minute via central line.
Waiting for further instruction, doc. Let me know when I can resume.
Okay, I will do the TEE.
Transesophageal echography show the mobile echogenic material in the right pulmonary artery.
Okay.
How about now?
For now, hemodynamic are stabilizing. We can add mirinon, start from 0.4 microgram per kilogram per minute.
Okay, doctor, setting up mirinon 0.5 micrograms per kilogram per minute through the central line.
Okay, you may continue, doc. Be
Okay.
quick.
Thanks, doc. I'm suturing muscles. Alright. Done. I'm done.
Okay, thank you. For now, the patient is stable, but we don't have plan to do the extubation. Please prepare for the transfer to the ICU and continue the sedation and mirinon.
Okay, I'm continuing sedation and mirinon.
All right, I'll call the ICU and let them know we're coming.
Okay, good job, guys.
Good job,
Thank you.
Patient was extubated on day 6 and finally discharged after 16 days. Patient survived without any major sequel. Key lessons that we can learn from this case are early recognition and abandonment of futile intubation attempt. We can use front of neck access not only through our surgical methods but also with the existing wound that was provided life-saving airway control. We need to do parallel resuscitation and coordinate with the surgeon for optimized time to optimize care. Crisis management and closed-loop team communication is very important in early diagnosis of intraoperative complications that might happen, such as pulmonary embolism and bleeding. Finally, multidisciplinary coordination is essential for successful patient outcome. In conclusion, airway crash and airway crisis can happen anywhere at any time. It is very important that anesthesiologists stay vigilant, stay fast thinking, stay at their quick wit to ensure that this airway crisis can be handled. And we are the Trauma Guards.
Initiate, coordinate, resuscitate.
Thank you. Congratulations. How come it's unlucky patients, but luckily this patient stay in situ hospital.
Thank you. Very exciting. All emergency happening almost all the time.
Yes.
Right. Yeah. You would like to have some comment from?
Yeah. Actually, we have a special guest from China to comment, please.
Okay.
Yes.
Thank you for introduction team. You show me excellent case, rescue for traumatic emergency difficult airway management. Thank you. But in fact, situations of patients is maybe more complex. So I have a question I want to know. If this patient experienced aspiration before arrived at operation room, how should we do? Thank you.
Thank you. In this kind of emergency patient, aspiration is one of the one of the most important complications that can happen. We ensure the patient does not have aspiration by not giving by keeping the patient in Trendelenburg position, and then we do suction in especially with the rigid suction, because we expect blood clots and active bleeding from the wound that can get into the airway. And post-operatively, we make sure that there is no aspiration using chest X-ray and also bronchoscopy if needed. Oh yeah. Yeah. In the beginning, we expect there will be some sort of soiled airway and possibility of aspiration. That's why we use the salad technique.
Okay, thank you very much.
Thank you.
Thank you. Thank you very much. I really liked during your performance that during the intubations from through the wound, and you check that subcutaneous emphysema as well.
Yes.
So something happened. Never mentioned that. A lot of detail in this scenario as well. Some comment for the last performance, please. Not yet.
May I cannot follow why the patient developed a PE, pulmonary emboli form. Sorry.
You mean PE, pulmonary embolism, right?
Yeah, pulmonary embolism. Yes.
Yes, there are a lot of different risks from this patient. This patient is with open airway and vascular injuries from the beginning, so there can be air coming in, and intraoperatively there's bleeding that comes from the vascular anomaly that can also cause pulmonary embolism.
Because the surgical field is higher than the heart, right? But you diagnostic that before intubate, before the scanning or something, right? You're concerned about that before.
Yes.
That's great. So thank you very much. Congratulations, Sipto Hospital.
Thank you so much for the last tip of the day.
Woohoo!
Yes,
Thank you very much. So now it's a very difficult time for the judge.
Yes.
The first is judge may would like to go for the washroom because they just stay from 1 a.m. until now. It's almost 5 a.m. with 10 teams, right? And could you please send your last score to the scorekeeper, and this score will calculate depend on the judge. If you just stay until the end, this score is powerful.
I think they already done
right?
the scorings. Can they taking a break? You allow?
Right. The judge can go for the washroom, but in the meantime, I will announce something. During we calculate, we need about 5 to 10 minutes for calculate the scoring. And in the meantime, I'd like to show you that you can still go for the popular vote.
Yes,
in the last 1 minute.
Right in front of your face at your table, they have
The last
QR code
1 minute.
everywhere. You can
popular vote.
scan. Only one team, one time for you. For the popular award. For 10 teams can have that.
Okay. And what is the scoring system?
I think we still
not
have...
Yet, not yet. Okay.
I think you can show the award. What award do we have? I mean, comment
no.
provide.
Do you know the award of this competition is what? Before I describe about this award, as a cost director of this competition, this is the first time ever of the whole Asia, I would like to thank you, Comments, to make this competition happen. As first time in the whole Asian Australasian, it's really difficult and hard work for Comments to do this.
Yes, please keep comment around applause. And all the supporter staff right there, they score right now, but they stay there for like 4 hours. Yes, to back up for all the team. I think they're back there at behind the room. Yes. Thank you so much.
Do you think we learn a lot from different scenario? Because at the beginning we announced this competition, we not fix the scenario, but finally we have 10 scenario, totally different 10 different scenario.
Yeah, how come you select to be like totally different?
Right, it's random like this.
Really?
And we can use this video because we record this video. We can use this video to teach our young staff or our hospital for the anesthesia non-technical skill as well, or something. We don't have to do this again in our hospital. We can use this video to teach as well. It's feel free to use it, and comment will distribute it, right? After this, thank you very much, comment for this.
I just wondering how excellent random selection can select like CVT, liver transplantation, single ventricle baby, pregnancy, woman, wound, trauma, injury, and all those kind of different. And we can learn from all of the cases, and also all of the audience, also the judge and all the special guests.
You know, this is top 10 team of the whole Asia because a lot of teams send the case, but we select this top 10 team. Many countries sent, but we not selected because it needs some develop a little bit, but this case is wonderful 10 representative. So I describe the
prize for the champion.
The prize of the champion of the whole team, 10 team, is the champion's token. And then all of the team can have a flight to show to the world. Show this scenario to the world. At least start with go to China first. And then the most important is your hospital can have one anesthesia machine.
Very high-end XA.
How much does it cost? How much?
20,000 US dollar. Whoa.
Almost 8 million baht.
Our hospital cannot have that. So sorry for that.
Dr. Hasmisi
don't have a
informed me
chance
that.
right now to
Dr.
have
Hasmisi
that.
informed me that if they win, they will buy, they will sell. And
Maybe one of our hospital in Thailand can have that. Maybe we don't know the result yet, but we cannot have that. Okay. PSU Chiang Mai, no chance. Okay.
And all of the performer or the winner can have, what is this? Pocket, what is this one?
Maybe Gary can explain.
Explain, please.
It's the pocket video camera to take the vlog. Like selfies or take the scenery.
Selfie and cycling as well.
Yes.
Running as well. Wow. Thank you very much, comments.
Thank you so much. You were so kind.
And the second runner-ups will receive
next prize.
Share to the world as well and go to another country.
2 teams can have
starting
it.
from China. And also we will have excellent monitor, bedside monitor, exists with high quality advanced hemodynamic as well. High-end multi-parameter patient monitor device.
K18, yes, and also it's a different from the champion Osmo Mobile 7P.
It's the gimbal to take like video gimbal like this. Yes.
Wow.
Thank you.
And
thank you.
We also have the next prize will go to, I cannot move. Okay, the Outstanding Performance Award will receive the token plus defibrillator monitor as well.
SX defibrillator monitor. How about this too?
Maybe the competition persons feel like fatigue. We need some neck massage.
Super tired at the end of the day.
Neck massage.
Okay.
And what is this? This also can massage anywhere, right?
Right.
Anywhere.
Pressure point, something like that. Yeah. Very nice.
So good.
Yes.
And the last but not least is the most popular award.
Yes.
Most popular award.
Voting, everybody can do that.
What it is?
Very cute.
It's the year of horse, right? This year is the year of horse.
Chinese
lucky.
horse year.
This is lucky.
Year.
Lucky.
Yes.
Okay.
Because in China, we have the saying like, if the horse is surviving, that means we will get the success in our work and the life. So this is very good meaning of like the good thing.
China words, please.
马到成功。
马到成功. Wow. Excellent.
During we waiting for the score. If score is ready, tell me. During we waiting for the score, I would like to have the feelings of the judge. Feeling of the judge that you stay for the whole 10 teams. And this is first ever that we do these competitions. This competition is not for compete that which team is treated best, but just to encourage all of people in Asia to do
but they
something
haven't
like this.
have a chance to taking a break yet.
Yeah. Please have the comment from Lawrence first.
Yeah, well done to everyone, particularly both of you for moderating and chairing this. I think a big congratulations to our moderators. What a privilege to be part of. Such talent, so much learnings, such an educational experience. I think I speak for most of the judges today. We thoroughly enjoyed what we saw. I think everyone learned something, and everyone will walk away today with feeling a little bit more inspired, learning how to communicate, learning how to perform teamwork, and just being privileged to such a terrific educational session. So thank you very much and congratulations.
Thank you so much.
My feelings, just like Lawrence, was very educational, and I was first I had some doubts. 10 teams, such long time, maybe people lose interest and everything, but tension was very high up to the end. It was a very educational session, and I was also very proud and moved to see that anesthesiologists take the role of the leaders in the operating room, in the emergency situations, and it's a great session. Thank you.
Our session is still full. Thank you to everybody.
I would like to really congratulate all the participants who has put, I believe, a lot of effort. Okay, and I do agree with the rest that we have not only enjoyed the presentation, but also we learn a lot. So even though we are relatively a bit senior here, but I still learn a lot from the discussion and the presentation. And I didn't realize that we have such a lot of talent to become actor and actress. I think a lot of movie can employ them much better rather than employing the actual actor than actress.
Yes.
So there are
they're so much professional, like from the star,
professional
like from the
actor and
movie.
actress for all the production. Thank you very much.
Thank you.
I'm Biswas from Nepal. So this is very great scenarios that we create, and the competition is pretty new to me. To be a part of it is very. I'm very happy to be part of it, and it's very knowledgeable. I congratulate all the team from everywhere to act like it's a real scenario. To tell you the truth, I have been through most of the scenario except for 2 or 3, like neonates. But I have been through all the scenarios. So it's a great forum to see that the team from everywhere in the world speak the same language, same moment, same decision like Russian guys were telling. Thank you. Yeah, thank you, everyone. Yeah.
Thank you.
First of all, big round of applause to the teams who has shown the highest level of professional competency, skills. Big round of applause to all the teams. Big congratulations for the idea and organizing this competition. It's a great learning experience. It's very interactive, where we could learn live how the guidelines and protocols can be implemented in the real-time scenarios. Excellent, excellent, very excellent.
Thank you very much.
Congratulations to
please.
all of the hospital teams. You all did good jobs. And also thank you so much for your wonderful performance. I think these cases selected and the anesthesia management were both successful. And the way this requires our anesthesiologists possess very specialized knowledge but also rapid clinical decision making and also the effective communication with the surgeon and nurse and also well coordinated teamwork and pressure. So I think we all learned a lot. Thank you so much for your performance.
Thank you very much. Do you know China started doing competition like this for a long time, right? And we upgrade the version from China to this version throughout the world for more internationally. Thank you very much.
Excellent idea from the moderators, the participants, and the judges as well. As everyone said, we are still learning. If Dr. Suhaini is learning, I'm also learning. So we are all in a learning phase, and we learned a lot today. And this will definitely reflect the audiovisual that you have mentioned would reflect so that others will also learn how this simulation should be done in a real scenario. I remember myself in looking at all these scenarios, being one of the witness or as a physician, and it was a good learning experience. Thank you.
Thank you very much. Thank you very much. And to
Dr. Alexia, please.
Thank you very much. Thank you very much for this competition. We have gone here from Russia with love. We have found love here. I congratulate all of us for this big holiday, big celebration of our specialty of anesthesiologists and intensive care. Thank you very much.
Thank you so much. And to treat all the judges properly, because it's strong working today, to treat all the judges and to treat all the competition teams, 10 teams. After this, we will bring all of you to the beautiful river in the river cruise of Bangkok and enjoy the view together after this.
Yeah, please join us tonight. Do we have
Score ready yet?
Scoring result ready?
Ready? Okay,
Yes.
come on.
Okay. So exciting.
So exciting time. What it is? Oh, okay. Please open I will announce the first prize first. Okay. What is your sequence? Champion, okay. We will start with champion. Wait. I have to read it carefully. Okay. Okay. The sound. The first prize go to Malaysia. Please, Malaysia, come up on the set, please. And may I invite Professor Lawrence Weiberg to give the prize first. The token is very important. Take a very good photo And this photo will be in front of your hospital. In front of your hospital. Champion of the whole Asia and Australasian regions for the first time ever competition. And may I invite Professor He, Dr. He, Mr. He, to give the prize. Next is very important one is next one important one is the anesthesia machine. Anesthesia machine. No, wait. This give this one. No, give again. Please. Thank you. Very important photo. Very proud of you. Thank you very much.
Excellent team. Champion for today. Now we have another two prize from first rounding up.
I have to say that the champion score is 86.4.
Very close.
86.4.
Yes.
And the second is almost the same, but I will not almost battle like this. So may I announce for the next, the first runner-up. The first runner-up go to Silirat Hospital, Thailand. Silirat Hospital, Thailand. The first runner-up of the whole Asian Australasian region. No doubt for the first prize, no doubt for the first runner-up. Congratulations, Silirat Hospital.
Congratulations.
Thailand.
Finally.
May I invite Professor Jack Wang Chim to give the prize, please. And Mr. He to give the prize as well. Professor Jack Wang Chim, please. Token for the first runner-up. Photo, please. Congratulations to Silirat Hospital, Thailand, the first runner-up of this competition. Thank you very much. But we have the equal number. We have the equal score of the first runner-up. We have two first runner-up. The next first runner-up go to Russia.
Congratulations.
Okay. May I invite Dr. Suhaini to give the prize, please. And Mr. He to give the prize as well, please. It's very loud. It's far away from Moscow to come here. And this is the first runner-up of the whole Asian Australasian region. Congratulations, Russia, Moscow Regional Research Institute of Obstetrics and Gynecology, named after academicians Congratulations to Russia. Next prize, we will go to the outstanding performance. The outstanding performance go to the boy band of Thailand, KKU.
KKU.
Congratulations, KKU. Outstanding Performance Award. Okay, Dr. Biswas, please. And Mr. He, please. And Dr. Biswas, please stay on the stage. Okay. And Gary, please. Defibrillator from Gary comments, please. The next outstanding award go to
Sunwoo Hospital, China. Please come. Congratulations.
After this, may I invite Professor Yao Shanglong, please. Yao Shanglong 教授, please give the award, please. Porto and Mr. Gary, please. After this, I will announce the Outstanding Performance Award and the same number, same scoring. It's random. The scoring is random. I will not announce by sequence. Next Outstanding Performance Award go to Sito, Indonesia.
Indonesia team.
This scoring system of the Outstanding Award is mixed up, though no sequence, the same level. Congratulations to Sito, Indonesia. May I invite Dr. Ashi. And Gary, please. Congratulations, Indonesia.
So the next Outstanding Performance Award goes to China. Zhongshan Hospital from China, please come up on stage.
award go to Futan Dashi, right? Futan University, Zhongshan Hospital.
Zhongshan Hospital from China. Yes, please I invite
Congratulations.
Professor Ting Ting Wan give the award.
And Mr. Gary, please. Mr. Gary will give the defibrillator. The photography is very important because we will show this one in front of the hospital, right? Congratulations. Congratulations to Futan Dashi.
Congratulations.
Next award go to Saudi Arabia, please. And I invite Dr. Niran to give the award, please.
From King Abdullah Special Children's Hospital.
And Mr. Gary come up on stage to give the award of the defibrillator, please. Congratulations, Saudi Arabia!
Congratulations.
Very wonderful performance, outstanding performance award. Congratulations. Next award go to India.
Bangkok CIMS Hospital.
May I invite Professor Jeong Yun Suk. Professor Jeong Yun Suk, please come up on the stage. Jeong Yun Suk. Give the award, please. And Mr. Gary, please. Congratulations to Marengo CIMS Hospital, India for the Outstanding Performance Award. And the Outstanding Performance Award go to Philippines.
Philippine General Hospital.
Philippines, please. And may I invite Dr. Erinda. Dr. Erinda to give the award, please. And Mr. Gary to give the award. Philippine General Hospital, Outstanding Performance Award. Congratulations. We are proud of all the team because they do all the hard work. They perform, they practice. Last night we sleep very late after midnight to practice this since the afternoon of yesterday until midnight of yesterday. Long time, and we do the online practicing for a long time. Thank you very much. And the last award is the Popular Award.
Popular Award.
Let's guess who will be the Popular Award.
So what do you think? Which country do you vote? Did you vote?
The most popular award. The most popular award go to.
Which country you think? India. Who else?
Indonesia.
Malaysia? Indonesia? Else?
Go to Russia. Mr. Mr. Gary, to give the host and
Congratulations, you guys.
may I invite Lawrence again. Lawrence again, please. Professor Lawrence Weinberg, please. The most popular award. Congratulations for the great performance and wonderful case performance.
One team,
And
one
then-
moment, one decision, right?
May I invite all the team come up in the front and take group photo, please, with the award. Please come up in front, please. All the team, please.
All the team, please come
All
up
the
on
team.
stage to take group photo.
All the team, please. And we take the last group photo. And then after this, we will go to the boat, the cruise, enjoy the scenery of Chao Phraya River. All the team, please take group photo, the last photo. All the team performance, take group photo. And thank you very much everyone for joining. Thank you very much. Goodbye, thank you very much. Group photo, please. And change the screen. Can you change the screen? Okay, please. Congratulations all of you.
Can we remove the podium because we're going to run
And
out of the space?
yeah, the first team in the middle, please. Yeah. First team, second team. Or maybe you can mix up to you, okay? Group photo. We have only 1 minute for taking group photo. Now we have 50 seconds for group photo. And the judge, please join the photo, please. The judge, please. Comment, please. Comment together, please. Okay. One, photo, please. Ready? 1, 2, this smile. Okay, please. The judge, please join the photo, please. The judge, please come. Join.
Please, all the judge,
Yes,
please come.
Please come. The judge, please join. Thank you very much, comment for support such a great event like this. Okay, wait a moment. Congratulations! Yay! Congratulations! Yay! Thank you very much. Thank you very much.
Thank you so much for
Congratulations all of you.
this great
After this,
afternoon.
enjoy the party in the river together. Congratulations. This event make you have the connections. After this, we will have socialized connection. Congratulations all of you.